going to go ahead and get started here. Apologize for the delay, but you know, sometimes technology does not always do what we ask for it to do or expect it to do. And for me, if I push A and A doesn't happen, I need a lot of assistance. If you're looking at our agenda committee, you will notice that for the 9 o'clock is just our welcomes and announcements. And you've got 1, 2, 3, 4, 5, 6, about 7 different items on there. You'll find that in written form. And then the next is the written only testimony on KanCare from individuals, providers, and organizations. I did make the decision that because of us only having one day in the middle of our legislative session, that we would make sure we still heard from our individuals that wanted to communicate with us. So please make sure you take the time to look at their testimony at some point, but it gets us through to some of the items that we really need to take care of during the legislative session. So you've got several individuals on there, as you will notice. So we will start, as you flip to the second page of your agenda, and we will start at our 9:05, which is a discussion on the Mental Health Intervention Team Program, also known as MHIT, and I'll recognize John Calvert, Head School Safety Specialist for the Kansas State Department of Education. Welcome to the committee, John.
Thank you, Madam Chair, members of the committee. I appreciate the opportunity to once again come in front of you. First, I do want to apologize that you have to start your Friday morning by looking at this. I know it's not pleasant. I will try and be as brief as humanly possible and provide you the best update that I can while focusing on the funding for the MHIT grant. The MHIT grant has been in existence now for 6 years, has been in the proviso for each of those 6 years. It focuses on K-12 students and their families by identifying the kiddos inside the school and connecting them to the already existing mental health programs in the communities, whether that be private or public. And it focuses additional resources on those kids. We've been tasked with trying to focus in on the kiddos in the foster care system. And so we partner very closely and work closely with our foster care contractors and trainings for our liaisons. It helps break down those barriers that are unintentionally already put up for our kiddos and their families as far as receiving mental health services. And those barriers might be Johnny lives 45 minutes away from the facility, so parents have to take a half day or a full day off of work. They have to spend their gas money to get to the facility. The kiddo misses a half day or a full day because if their appointment's at 11 o'clock in the morning and mom or dad goes and picks them up at 10 a.m., by the time it's done and it's 12:30 and the kiddo gets lunch and drives back, now it's 2:30, and why go back to school for an hour, or why go back to school for 15 minutes? So truly breaking down those barriers, because we are offering the services, the therapy, the case management, the group inside of the school. So our liaisons work very closely as that bridge, or as the center fielder, as I call them, and work with the schools, work with our mental health providers, work with the families, work with those kids to get them out of a class, have them go through their therapy, their group, their case management. 45 minutes, an hour later, they're right back into class. So they're not missing the same class every time. They're not missing chunks. The parents aren't having to take time off work. They're not spending gas money. It truly is inside of the school. One of the things that we have focused on, especially the last year or two, is that we are seeing our kiddos as individuals. They are not, and we are not comparing them or trying to group them in with others or in pretty sections. Every single number that we see, every single kiddo that we talk about is an individual child, is an individual who may need specialized care that is just for them. So we are not going to try and group them into sections. Saying that, we do monitor 4 different realms, what happens is that our liaisons or our school districts identify 1 or more areas of concerns that we do want to help monitor a little bit, and those are academics, attendance, internalizing behavior, or externalizing behavior. And like I said earlier, those liaisons are the bridge working with everybody and anybody. And the one thing that I really want to highlight and make sure that I say out loud is that this is not done in a silo. We are not building a castle and raising our drawbridge and saying we're doing amazing. We are involving everyone. There's a memorandum of understanding between the mental health providers and the school district so that information can be shared. And more importantly, there's a release of information between the mental health providers, the school districts, and the parents and or the guardians of those kids. We are truly working from a community standpoint, bringing in all of the help that we can get and getting all of the different information from all the players. The question I get most often is, what if the parent doesn't want to participate? They are given the information. They are told that this is here. They are told that there are other avenues that they can go to. But this, without a release of information signed by the parents, they are not enrolled in the MHIT program. We have got to include the parents, the guardians, and every other stakeholder in this child's life so that we can get them the help and guarantee them the success that they deserve in our K-12 schools. We talk about funding. I was told I needed to focus on funding, so I'm going to focus on funding now. As I stated, since 2018, this has been in the proviso bill. So year to year, we are gathering provisos to make this program happen. As of now, the way it's written and the way it's been written in the bill is that 75% of the funding goes towards the liaison salary and fringe benefits. So the school district matches the last 25% to make up that salary and fringe benefit. The districts receive no extra funds for this. This comes out of their pockets, their budgets. 25% of the total request, or a third of that 75%, flows through the district and to the mental health provider, so that the mental health providers receive some funds for travel expenses, for uninsured, underinsured, for maybe their caseload is a little less because they do have to travel to the school. So to help make that up, they do get the flow-through money. And as an example, if a district applies for a $50,000 liaison salary with fringe benefits, the district would receive $37,500 from this grant. The remaining $12,500 is matched by that USD for that salary. The district then receives a total of $12,500 split into quarterly payments, or as you see here, because I couldn't do the math, it's $3,125 as flow-through money from the grant through the school to the mental health provider. The MHIT program is currently being conducted by myself and our part-time field liaison coordinator, Angie Brungard, who travels the state, does amazing work, does check-ins with all of our liaisons, hosts monthly meetings, goes and does face-to-face meetings with our liaisons, and sets up on-site training there for them. The positions are both funded completely by KSDE, and no MHIT funds are being used to pay for our salary or this program through KSDE. In 2023-24, this current school year, we were allotted $13.5 million from the legislation. We had $13.2 million requested by 90 districts and their mental health providers. That means there's about $300,000 out there that wasn't spent this year. That money will roll over, per legislation, will roll over back into the program next year. So again, every dollar that we get as KSDE from this grant goes right back out to our schools, goes right back out to our kids, so that they are receiving the services that they so desperately need and want. We are not taking a dime. All of the portal services, our IT, everything that we're doing at KSDE is funded through KSDE, not through this grant. Like I said, in 2023-24, this school year, we have 90 school districts. We have 182 liaisons. And as of our progress report from that first semester, which goes from July 1 until December 20th, so realistically, we're talking maybe August when school gets started through December 20th, we served 5,732 students. That's over 5,700 individual kiddos that are getting services through this program, and that is so amazing. And for first semester numbers, of those, 477 kiddos were identified as kiddos who were in the foster care system. things that we have to consider, that I have to remind myself when we are doing our meetings and our check-ins, is that some students may still receive mental health services outside of this grant. Maybe they have a provider or a therapist or someone that they already have a previous relationship with. We don't want to discourage that. We want that to continue. And so they might not participate in the MHIT program for a variety of reasons, and that's okay. We want to make sure that they know that these services are out there. We want to make sure that they know that if they need help, there is assistance, and not only for the kids, but for families as well. There are districts out there that will do family therapy inside of the school every so often so that the kiddos can get the therapy. The family is involved. Our districts will open up their doors over breaks, over summer, to allow the kiddos, the families, to come back into the school and continue to receive these services when school is not, quote unquote, in session. Every program has to be a little different. Every kiddo is a little different. Every community is a little different. So we don't want to strong arm and say this is how this has to work in this box. We want to allow the freedom for our mental health providers, for our guardians, our parents, our liaisons to be those experts in those kids' lives, to open it up and say to the kiddo, to the family, what is it that you need? What is it that you are seeing? And allow them to be the experts, and trusting them in making this program the success that it has been. And I always end with success stories. I always tell everybody, if you're having a rough day, come on over to my cube. I will show you these success stories. I can tell you that there are days dealing with school safety as the head of school safety for KSD. I have rough days, and I love opening these success stories and knowing that this program that you as a committee fund and support, that the State Board of Education supports, that it is just amazing what we are doing and what you have allowed our school districts to help our kids, and our mental health providers to come in and help our kids. I love just seeing things like he's made a lot of improvements this year. He had several behavior referrals last year and was failing almost every class. He's now passing all of his classes. He had no behavior referrals and is generally happy to be in school and in all of his classes. We are changing the trajectory of some kids' lives by just allowing them to get the services that they need. And why this matters and why I will continue to fight for this program year in and year out is I always get success stories that say, from my high school student, my therapist saved my life. And when we start thinking about, oh my goodness, statistically pre-pandemic numbers said that 1 in 13 of our kids will attempt suicide. Not think about, not talk about, not have a plan, not post about, but physically actually attempt. And we say that we served over 5,700 kids this semester alone. We are saving lives with this program. And so I appreciate the opportunity and the responsibility that you have given me to head this program and to make sure that we are continuing to do what's best for kids. And with that, I will stand for questions, Madam Chair, at the appropriate time.
All right, I think what we'll do is we'll go through all of our individuals that we have, and then we'll come back and ask questions at once. Thank you, John.
Thank you, Madam Chair. Thank you.
Next, I have Jennifer Light, Fiscal Analyst for KLRD. Welcome.
Good morning, Madam Chair, members of the committee. I have 2 documents for you today. The first is in a packet on your table. It has a map of the state of Kansas with the different school districts that are doing the MHIT program this school year. On the back of that is a list of the 90 school districts that was provided by KSDE. We just put it together on this one document to make it easier for you to look at. I'm going to focus on the funding aspects of this morning. On the back side of the page where it lists out all of them, you can see in orange on the left-hand side, those school districts are the new school districts that have joined this year. Also, in the purple column where it says state grant amount recommended, there are 6 different sections that have school districts that have green. Those are the school districts that were have been in the program since the first year. This includes 259 Wichita, 435 Abilene, 457 Garden City, 500 Kansas City, 501 Topeka, 503 Parsons, and then there are 3 school districts in the Abilene area which are participating as part of a consortium, and that's 393 Solomon, 473 Chapman, and 487 Harrington. Why I bring this up is because those 9 districts do have a different funding formula. The first year of the program, the CHMC's amounts was determined based on the agreements between the districts and the CMHCs. When the legislature determined the amount, the original 9 were able to then choose between the amount that they had agreed to originally in that first year. If it is higher than what is the legislature's formula, which is the 1/3 of the current school year's state grant amount for the school liaisons. So those 9 districts do have the option to choose between how they originally set it up, if it is higher than the 1/3, or they have to do the same as the rest of the programs where it is the 1/3. I also want to touch on a point that the MHIT program is a portion of state aid that goes out to school districts, so you will see it listed in KLRD documents under state aid. However, I do want to point out that it is not part of the school finance formula at all, so it is not part of the major areas of state aid when we talk about state foundation aid or supplemental state aid or any of those. So it is its own separate state aid that goes out and only goes to the school districts that are participating in the MHIT program. I have also included for you guys, I do not know if this was printed for you, but it is included in your online packets. It's just a memo that works through all of the different legislation that we have done over the last 6 years for the MHIT program. And then just one quick touch that we started with in fiscal year 2019, the legislature appropriated $10 million for the program. And that was for the pilot itself to create a database, and then for the school liaisons. In fiscal year 23, the legislature appropriated $10.6 million, and then for fiscal year 24, it is $14.4 million. It is that $13.5 million, and then there is $886,000 that was reappropriated from the previous school year. And with that, I'd stand for questions.
All right, thank you very much. And next, I've got Kyle Kessler, Executive Director, Association of Community Mental Health Centers of Kansas. Welcome to the committee.
Thank you, Madam Chair. Members of the committee, I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We appreciate the opportunity to appear here this morning to provide comments on what we believe has been a very important program, a very successful program in the mental health intervention team, and what it's been able to accomplish for the kids around the state. Really, with our written comments, you get the first page is really the history, the second page is the dynamics and the process, which you all are familiar with, and along with some statistics and the roles that each player provides. I think that's been covered well. Certainly our partnership with John and his team at KSDE has been very important, along with the work that was done on this program through the course of time by Sue Moran in our office, as well as Diane Jerstead. Many of you know Diane, and they've been champions on this program since its inception, really. And so what I was going to touch on briefly was more the funding side as well. And just to give you an idea, since your purview is the Medicaid funding pieces, we did a sample, which I can submit to the committee if it's helpful later on. But in looking at 8 different CMHCs and how the students fall out in terms of the funding sources, they really range from about 60% Medicaid to 90% Medicaid. And that's going to depend on geography, as well as obviously which school buildings or school districts that you might be in. And so anywhere from 5 to 10%, close to 15 in one place, are uninsured. So that's where the subsidy for the community mental health or mental health liaison and therapist comes into place for the CMHCs or other providers. And that can end up ringing up a bill. And the example I would give is there was a case in Central Kansas where the mental health center had worked with a family to do a payment plan because they didn't have covered insurance, and they felt like the youth could use psychosocial group and some other services, and that worked splendidly. They put the family on a low-cost monthly reimbursement or repayment plan, but it was also subsidized significantly by this by the dollars that came through the mental health information treatment, or I'm sorry, the MHIT program. Then on the other side of that, same mental health center provided a story of a family who also, for their child, needed services and went on a payment plan. It ended up with a bill of around $4,000 and never made a payment. And so this program helps subsidize that student's mental health services, which were very important. I think both cases have resulted, my understanding is, successfully closed cases, getting kids timely treatment and timely access to services in a structured setting. So with that, I would stand for questions at the appropriate time, but, and again, in terms of the private insurance, it also ranges anywhere, and commercial insurance ranges from anywhere from 2% to 25 to 30%, depending on location. So we see a wide variety of funding service arrays, but the funding attached to this program, which has been so significantly championed by both the executive branch and the legislative branch over time in the last 6 years, has been really important to us making significant strides in youth behavioral health. And with that, Madam Chair, I would stand for questions at the appropriate time as well.
All right, thank you very much.
Thank you.
Next, I have Sue Murnan, Youth Behavioral Health Services Manager at ACM HCKS. Welcome to committee, Sue.
Good morning, Madam Chair and members of the committee. I concur with all the testimony that was provided and don't feel like I have a whole lot to add other than the benefits of the program. Coming from a child welfare background where I worked in foster care and adoption work for over 20 years, I feel that the benefits for this program are substantial. Children are missing less school to get to and from appointments. Families aren't having to worry about the transportation difficulties. Parents, when they are required to participate in a meeting that's required with the MHIT program, they can connect via Zoom or telehealth, which makes it simple for them to participate when needed as well. So there are many, many benefits to the program. And like I said, I really have nothing more to add unless there are questions for me.
All right, thank you very much, Sue.
Thanks.
Committee, are there questions for any of our conferees? Senator Petty.
Thank you. And Jennifer, maybe you can update this for me. I thought I put down a figure that you said the funding was 10.6 for 2023. And is that correct?
Madam Chair, that is what I said. I misspoke. I apologize. That is what was appropriated. They spent $9.7 million.
Okay, so I'll follow up with that with Kyle Kessler, because Kyle, you mentioned that the funding, and you have it in your testimony, was through 13.5.
I believe that was the reference to the appropriation.
Okay. I'm trying to decide.
I think Jennifer's got some clarification
thanks,
here
Jennifer.
for you, Senator.
Madam Chair, the number, when I was talking about it, was for school year 22-23. The 13.5 is for school year 23-24. And then there was the additional reappropriation of $886,000, which puts us at $14.4 million that is currently appropriated for school year 23-24.
And I believe in the governor's budget for this year, she added an additional 3 to that. So would that put us at 16?
The additional 3 is for fiscal year 24-25. So it would be the 14.4 and 24 for fiscal year 24 or school year 23-24, and then 16.5 for fiscal year 25, school year 24-25.
Right, and that would be for the budgets we're currently working. Go ahead. Yes, Senator Petty.
So for the 24-25 school year, it's 16.5. Is that correct?
That is correct.
Thank you.
Committee, further questions? Representative Reese.
Thank you, Madam Chair. My question is for John. It's always great to hear your presentation because you can just tell how devoted you are to this program and knowing how important it is. One of my questions is, well, my question is I know that there's a partnership with the mental health centers. Are there other partnerships with, like, private therapists?
Oh, absolutely. So the one thing that we want to make sure is that the child can receive 24/7 care. So that has to be in that memorandum of understanding that the school districts partner with those mental health providers. But if there are community mental health centers, private providers, whoever's licensed and wants to come in, yes. But what we don't want, and what the chair always brings, is that kids don't go into crisis 8 to 4 Monday through Friday. It's 2 a.m. on a Saturday morning, and who's going to get up and who's going to come help that kiddo who's in that crisis? And so you can partner. Our school districts, per legislation, can partner with any provider, private or public, that they so choose. We do want that 24/7 care to help those kids.
One more question. John, do you know if it's a private provider, are they able to also bill Medicaid? Or, I know they can probably, get reimbursement through private insurance, but I was just wondering about the Medicaid reimbursement.
I believe that they are still able to bill the Medicaid. That might be it's dependent on the price.
It's dependent
the
upon their
practice, I'm sorry.
licensure, I think.
Yeah.
Yes.
Okay, all right, thank you.
Yeah, and I don't know, Kyle, can you address this a little because all right, let's back up just a little bit. There have been other providers outside of the CMHCs, and this is a decision that a school district makes. What we've run into is occasionally a provider that says that they offer 24/7 services, but what they do is they hand out the CMHC number for those 24/7 services without a MOU or any communication with that individual. So that's why it makes this so important that we keep that continuity. But I think for others outside of this or some of our larger organizations, it depends upon the licensure of the individual providing services if they can bill Medicaid. Would that be correct, or am I totally confused?
Well, I think there's a couple of different things. If I understood Representative Reese's question right, was can private providers bill Medicaid for therapy codes and things like that? Yes, there are some, but those have really, you've seen fewer and fewer private practice therapists take Medicaid over the years. Now, to counter that, I would also say, from our perspective, and since we're in the Medicaid Oversight Committee, the MCOs have been really good on this issue. I think initially they saw quite a few blips and increases in utilization and billing, and they asked a lot of questions about that, but very quickly were educated by, I think, this committee and the executive branch that this was a program, and to my knowledge, we haven't had any providers get a lot of pushback from the MCOs on this particular issue. But I don't know, did I answer your question, Representative?
Yeah, so the school district can decide who they want to contract with. It's just that they've got to meet the criteria that is outlined within the program.
And I would add, we have not seen, to my knowledge, again, this year, any issues where there were private providers that were doing here's the mental health center's phone number without the mental health center knowing it.
Right. And then, as you said, Representative Reese, is that then they can also bill private insurance. And then, remember, no child is turned away. So if they don't have the ability to pay, they get covered. Representative Ballard.
Thank you, Madam Chair. I'm not sure if it's John or Kyle, but when we talk about providing 24/7 services for the students or the children, what do we do in terms of their families so that they understand what's going on too and what role they play in it?
Absolutely. Thank you for the question, Madam Chair, members of the committee. Like I said, to be involved in this program, the parents sign that release of information. The parents are made aware all the time, and they are kept up to date. Our therapists, our liaisons want to know what is it from a family perspective, what are you seeing at home? Because this is what we see at school, what are you seeing at home? If there's an emergency situation 24/7, that parent has the phone number to the therapist, has the phone number to the CMHC, so they can be the ones who are addressing that need at that time. The child can call, but again, that parent or the guardian is looped in because I would hope that if their child is in crisis that they know, but we definitely want to make sure that the families are involved as well.
Okay, maybe I should have been more specific. do you have them there personally, or are they just filling this out on a form and giving you that information?
Actually, Representative, I think I could answer that because I understand where you're coming from with it, is that many of our schools, and this has been a benefit, especially in your small towns, because as we know, everybody knows everyone's business in a small town, is that there's many times that the school buildings are actually open later into the evening so that families can come and participate because the therapist may determine that it needs to be a family discussion. It may be, there was a death in the family, mom or dad has lost their job. So they can also help them find, services that the family may need. So they can direct them to the right places to get services.
That
So-
answers my question,
Yeah,
because
so it's in the
otherwise,
building.
there's a missing piece. It's like you're doing this and they're telling you what it is, but have they really interacted with each other so that they understand what that situation is?
Absolutely, yes, and that's what we want. We don't want any missing pieces. As I said, we don't want to build our castle and raise the drawbridge. We want to lower it, we want to interact. We know that this has got to be a community family approach, and I think the success stories speak for themselves, and the just growing of the program has been fantastic.
Well, thank you, John and Madam Chair.
Well, and Representative Ballard, you and I have worked on social services for many, many years together, and we've talked about true wraparound services. This program is definitely true wraparound to the entire family.
Thank you.
Representative Concanon.
Thank you. Thank you, Madam Chair. I'm not sure who to address this to, probably John, maybe Sue. I'm interested in foster care involvement in it. Do you get the parental permission? I guess several things. Foster kids are often more mobile than others, and how do you handle all that with transferring records, and do you have to get permission over again? And when you're wanting to know how the child is behaving at home as compared, so do you involve the foster parents or the bio parents?
So, Madam Chair, members of the committee, thank you for the question. Yes, we involve everybody. If that child is placed into foster care and the state has placed guardianship over someone else, the guardian is involved. Whoever has the legal representation over that child is the one that we go to. And so if it's the foster care provider, if it's the bio parents, if it's both, we have kiddos who are transitioning, just as you said. Sometimes you start in one place and you have to move. The great thing with this program is if you go to another district that has this program, that has the MHIT program, it's a number that we plug into our portal and it goes, hey, this child exited the program here, and boom, now they're here. Our liaisons talk to each other. Hey, I saw this kid's in your school now. This is what I can tell you. And they get connected through the private provider, the CMHC at that point, the foster care guardians or the bio parents, whoever has, again, that legal guardianship over them, they're involved again. If those change, if those people were to change, then we do go back and get the releases and we sign that paperwork over again. But this transition between one district to another district is very, very smooth because we use our portal. And so even if a child goes and enrolls in a different district, they might not know or think about, I need to tell them I'm a part of this MHIT program. The portal does it and alerts us all. So it truly is one of those things that can help the transition piece from district to district. And I hope that answered your question.
It does, thank you. I just will comment that I wish their school records would pass as easily. Thank you, Madam Chair.
Amen, Representative Concanon, on that. And I think that was one of the things that was unique in this program is that it was the foster children were always supposed to be the alpha children in this because we knew the great need that we had. And I do have to give kudos to Secretary Laura Howard because she was able to go in there as I just kept repeating and repeating, and she figured out what the glitches were, and she's cleared all those paths. So that's why we're starting to see the increased number in foster care kids. And that, bouncing from school building to school building, because in the online database, et cetera, they're tracked by their ID number. So we don't lose those kids. That's what's exciting about it.
Can I add something?
Yes, Sue, you may.
Yes.
You know more about this than I do, so go ahead.
Well, I've been working with DCF, and we've identified a way that we could identify youth in foster care as they're transitioning from one school to the next. So they did make an adjustment to their form that came out in January. So we're able to identify who the mental health provider was and if they were participating in this program, which will also help as they're staffing these youth that are transitioning from one foster care home to another or district to another. That's another way of identifying those youth in foster care. We've also done some presentations for the foster care providers on the MHIT program just to educate them as well. So we've been working closely with them I presented to DCF, Angie and I went and presented to, I believe, TFI? St. Francis Academy, and have reached out to the others as well.
Committee, further questions? Representative Reese.
One comment and then another question for John. In a previous committee that, John, you made a presentation, and I asked you about families that that English might not be their first language, and you affirmed that every effort is made in order to have interpreters, available for that. And I want to thank you again for that, and just for the committee to understand that. My question is, do you know who the youngest child is that services have been rendered to?
So I don't know the exact year, days. This service is for K-12 students, and so the youngest would probably be 5, maybe older 4-year-old, but we do have kindergartners who are benefiting from this service.
Thank you.
Committee, are there further questions or comments? I think one of the things that also gets lost in the discussion is not only the benefits that we're providing for these children and their families, but there's also a financial side that sets in all of this. It's easy to look at, whether it's $10 million, $13 million, and say, wow, that's a chunk of change. But if you look at that, this takes, not only pressure, I think, off of our schools, it also takes pressures off of the parents. At some point in here, I don't know whether we'll be able to track it, but it's got to be a benefit. And I think you can see that when you look at this chart, as we see the kids that graduate from this program, is that hopefully we have fewer and fewer children that end up in our juvenile justice system, that we will have fewer young people end up in our Department of Corrections. And it's also starting to remove, because of the younger people, the stigmatism. We've had children that, have gone into their teacher or whatever and said, hey, my friend's, struggling with help, maybe you ought to visit with him. Or they've actually had kids come to the liaison and says, I think I need help. And those are the things that we're trying to encourage. So there's, a whole lot of benefits. We will also see productive working individuals, which means less problems on the end with employment too. So any further questions, committee? All right, seeing none, thank you very much. Okay, next we have overview of Medicaid program expenditures. We have Dayton LaMunyon with KLRD. Welcome.
I'm not Dayton.
I was sitting here. Now, do not tell me that I have been calling her the wrong name. All right, welcome, Megan.
Thank you. If it's all right with you, I'll start, and then I will turn it over to Dayton after a bit. We are going to walk you through a very high-level look at the Medicaid funding and really looking at the way that it's categorized in some of the larger categories. So the first one that I'm going to start with is the division of funding between the two agencies. So Medicaid is unique in that it's funded across two different agencies, KDHE and KDADS. And as you're all aware, KDHE administers the financial and contractual aspects of the program, as well as the medical piece of the program, whereas KDADS administers the portions that are more related to behavioral health, nursing facilities, and waivers. And on the next slide, you'll see that division of programs mapped out a bit more. Under the KDHE program, we have medical services. That's what you think of when you think of standard Medicaid, when someone goes to a doctor or a hospital. KDHE also has oversight of the administrative pieces, so that includes the contractual aspects of the systems that help to keep all of Medicaid in line. The Medicaid Management Information System, that's one of their largest systems, which is something that helps them to track providers and the federal funds that need to be drawn down for the program. KDHE oversees the state plan. This is in essence the agreement that they have with the federal government of how the plan will move forward, or how the program will move forward. KDHE oversees the managed care organization contracts, and they also contract with actuarial services. All Medicaid rates must meet federal guidelines, so they work with actuaries to ensure that all of those guidelines are being met. KDADS, on the other hand, oversees, their programs are really divided into two categories, which we'll talk about a little bit more in a few minutes. The first is caseloads, and that includes CCBHCs, community mental health centers, those behavioral health programs, as well as nursing facility reimbursement. And then they also have non-caseload programs, which include the Medicaid waiver programs. So on the next slide, another way that you hear Medicaid categorized is KanCare and non-KanCare. KanCare is the state's managed care model. So this is the program through which Medicaid is delivered using the MCOs. KanCare services include medical services, so services provided by doctors and hospitals for general beneficiaries. The waiver services are included in KanCare, as well as Children's Health Insurance Program. Non-KanCare services are called also fee-for-service. And this means that rather than going through the MCO, the state pays these providers directly for these services that are provided under these specific programs. And some examples of those programs are the SOBRA program. This is a program for individuals who don't meet the citizenship criteria for Medicaid. It's a very limited program. It provides emergency care and delivery with no follow-up care. And these are individuals that would need to be able to qualify for the program. Otherwise, they're just not, they don't meet the citizenship criteria. Medican is another example. This is, again, limited services for individuals who are waiting for SSI approval. And this has a 12-month life limit. And then PACE is another example of a program that's provided largely through fee-for-service. On the next slide, another way that we hear about Medicaid being categorized is caseloads versus non-caseloads. Every year, we meet twice a year to go over the expenditures and create new estimates for the expenditures for caseloads. And caseloads are unique in that they are exclusively those programs that are entitlement programs. So these are the programs within Medicaid that are required, that the state is required to fill if a person meets that criteria. They're not able to have wait lists. Those services must be provided by law. So these include all the medical services through KanCare, certain KDADS programs, which Dayton will go over in a minute, and then also included in there are TANF cash assistance programs through DCF. The KDH caseload expenditures, the overwhelming expenditure within KDHE are the services that go through the MCOs for medical services. And caseloads do not include services for CHIP or expenditures for CHIP. And then on the next slide is a funding chart. And you should have a table of expenditures in your handouts. This chart is created using data from that table. So these are the actual historical major Medicaid program expenditures from 2014 to 2022. And in the chart on slide 6, you can see that blue portion of it are the medical expenditures for Medicaid. The green portion are the waivers, largely. These are generalizations, but largely made up of the waivers. And then the very small piece on the top is what would be considered KDADS non-KanCare. So those are those fee-for-service programs. PACE is part of that, as well as fee-for-service payments for nursing home is what largely makes those categories. And at this point, if it's all right with you, Madam Chair, I will turn it over to Dayton.
Now, you look more like a Dayton, so thank you. Welcome to committee.
Thank you. They do call me Dayton. I'm a fiscal analyst with legislative research, and I'm assigned to the KDADS budget. So as you can see in your slide, and as Megan kind of alluded to, the KDADS portions of this are broken into KanCare and non-KanCare inside of caseloads. So as Megan noted, these are all entitlement programs. None of these have a wait list. The KanCare portions include behavioral health services, which do include the reimbursements for CCBHC. So in the past years, you all have added funding for that, and that funding goes into caseloads, as well as reimbursement payments to the nursing facilities. And the rebase process based on statute is done through caseloads as well. So if you all add funding for a rebase, that would be added in to caseloads as well in the KanCare portion. And that second portion is non-KanCare. So this includes PACE. Previously, it was just, it was separated, but now all of PACE is inside of caseloads. It also includes fee-for-service payments for nursing facilities, as well as waiver and hospital assessments. So for individuals that are being determined eligible for those waivers or to enter into a state hospital. And as you can see on this page, the KanCare non-caseload, so these are outside of the caseloads process. These are not considered entitlement. They have or could have a wait list, but they're still KanCare programs. These programs are the HCBS waivers. There are 7 of them, and since they are not in caseloads, not entitlement, they are eligible for a wait list. And the IDD waiver does have a wait list. The PD waiver has a wait list, and the autism waiver has a proposed recipient list. If you continue to the next slide. This is a chart showing all of the waiver expenditures. So you can see the biggest blue part of the bar in the middle, that is the IDD waiver, makes up a significant portion of those expenditures. And I'm happy to stand for questions. As Megan noted, it's kind of a high-level overview to set some foundation, and we're happy to take questions if you have any.
Thank you. One quick question. Okay, we knew about the IDD, and then you said the PD waiver has a wait list?
Yes.
And what was the other one?
The autism waiver has a proposed recipient list.
Explain what that means.
Ooh. That's a good question. I'd have to get back to you on the exact details between them. They are individual. I don't know technically why it's called a proposed recipient list.
Yeah, I think it'd be good for us to have that information. What's the number on the PD list? Do you have that? If not, that's fine. You can get it to us.
I can pull that up for you
All right,
before.
that'll be fine. Committee, are there questions for Megan or Dayton? Representative Ballard.
Thank you, Madam Chair. Just a clarification. I believe when we were looking at it, the comment was made that no expenditures for CHIP. Would you explain that further?
That would be a Megan question, so.
Madam Chair, I believe that was in reference to caseloads. CHIP is not an entitlement program, so it's not included in the caseloads expenditures. It's just a general KanCare expenditure.
I believe it also sits in a separate statute too,
Well,
not in the Medicaid statute either.
Correct.
Okay, that's what where I was going to see. Did it sit outside of that? Especially if the parent, and they can't have a parent, would be in the caseloads. And the question was asked, when they go and they take the child and maybe they have multiple appointments, some people were confused in terms of they were being treated, but maybe it was just the individual taking them with them because they didn't have childcare or something along those lines. That's why I was asking that question.
Committee, further questions? Representative Concanon.
Thank you, Madam Chair. I told you I was thinking about a question because I'm trying to clarify the question in my own mind. It might be because it's Friday, but my question is on PACE. So it's a managed care system itself, but then it's listed here as fee-for-service. Is it fee-for-service to PACE and then they pay the provider? I'm just trying to understand that.
We'll get back to you on the details of the funding for PACE. You did
Okay.
stump us.
Thanks.
Say that. Representative Will Carpenter.
So PACE is based on a 10% less than Medicaid fee.
Okay, I understand what it's based on, but it's listed, it's a managed care, but it's also listed as fee-for-service. So I'm just trying to understand the difference there, of that process. Okay.
I can look
It's okay.
into the reimbursement.
I don't have to know.
Well, I can look
Just
into the
got curious.
reimbursement. It's good to know, all these details. I do have an answer to a couple questions. The proposed recipient list is different from the wait list because those individuals have not been found functionally eligible for the waiver, whereas if you're on the wait list, you have been. So that's the kind of technical difference between those. The other question asked was the wait list for the PD waiver is currently 2,361 individuals, and 6,067 individuals are served on that waiver currently.
6,000 what? I'm sorry.
67. That's the number served.
Representative Carpenter.
And what's the average length of time?
Boy.
It was about 28, 29 months. I'm
Yes,
not
it
sure
is.
what
It's shorter than the IDD waiver. If I recall from previous hearings from the KUCDD study, it was around a year and a half or 2 years. So I'll look into that and get that for you.
Thank you.
Further questions? All right, thank you very much. Appreciate it, both of you. Okay, committee, we did have scheduled the KanCare ombudsman. Unfortunately, she did have a family matter where she could not be here today, but we do have her testimony, so please make sure you review that. Next, I have a presentation on the Office of Medicaid Inspector General, so we'll welcome Steve Anderson, our Medicaid Inspector General. Welcome.
Thank you, Madam Chair. Appreciate the opportunity to appear here today and talk about the Office of Medicaid Inspector General, otherwise known as OMIG. I am Steve Anderson, the Inspector General. Just want to let you know that our 2023 annual report has been finalized and should be published next week. It'll be available at the link that's on the handout that you have. That same web page can also be used to access all of our prior reports and prior annual reports. I want to highlight a interim report that we published on November the 1st of 2023 involved recommending that Kansas schools conduct full fingerprint background criminal history checks on all school employees on a documented 5-year cycle. Our interim report indicated that 31% of school district employees who provide Medicaid services did not have background investigations completed on them. We found that Kansas schools can certainly receive about $2.35 million a year in Medicaid funds for providing services. Our audit involved looking at a sample of 17 schools within the 287 public schools that are available across Kansas. So therefore, approximately 3,731 Medicaid providers are out there working directly with Kansas kids on a daily basis. Our sample testing found that 31% of those may be working without a background check. Our report recommended that all school districts should confirm that employees have, regardless of role, a current background investigation on file. And we'd also recommended that legislators should maybe consider adopting a law requiring fingerprint-based criminal history background checks for all school employees on a 5-year cycle. We did note that the Kansas Department of Education requires a fingerprint-based criminal history check for licensed staff, but there are no state requirements for these people outside of what what the Kansas Department of Education requires. So they're doing that. We also did not find any requirement for other school employees, such as therapists, coaches, paraprofessionals, bus drivers, cooks, and janitorial workers, have any kind of background investigation done on them. Our overall audit of the school Medicaid reimbursements is still ongoing. The scope of the audit includes looking at all Medicaid enrolled students who had services billed on their behalf from a local education agency provider within a school-based program from January 1st, 2021 through January 31st, 2023. Our objectives were, of course, to find sufficient evidence to answer the following questions. Does KDHE have an effective system for processing and tracking school-based reimbursements for fee-for-service? It's all fee-for-service funds. Also, does KDHE have adequate policies and procedures that promote an effective and efficient school-based Medicaid program? And then finally, does KDHE and KSDE have sufficient oversight processes in place to ensure that individual education plans, IEPs, are complete and support medical necessity when services are being billed to Medicaid? We also have 2 other ongoing performance audits. The first one involves prior authorizations for Kansans, in Kansas for Medicaid recipients. The audit period covers January 1st, 2021 through December 31st, 2022. And we're basically looking to see, are there delays in the peer-to-peer review process under which managed care organizations deal with hospitals whenever they're dealing with prior authorizations. We're also looking to see our Medicaid beneficiaries being placed in observation status when they should be inpatient. And then last, we're looking to see is there consistency in how each MCO determines the level of care for a Medicaid recipient that's in hospital. Our second audit that we have ongoing that I mentioned involves the continuing care retirement community registration process and we're looking at that for basically potential fraud, waste, and abuse. We're covering the CCR certification process, and we're looking to see, are there currently issues within the legislative language that are allowing these facilities to falsely claim they're part of a CCRC? Are there compliance with the CCRC statutes? And are there measures that can be taken to stop potential fraud, waste, and abuse of federal matching funds? Aside from that, in cooperation with KDHE, we have developed a fraud, waste, and abuse awareness program. For calendar year 2023, we conducted 19 training sessions and provided training to 831 people. It's provided on an annual basis, and the purpose is basically to help people within KDHE as well as contractors and private citizens that are interested learn more about how to identify fraud, waste, and abuse and how to report it. I want to provide you with an example of a case that we recently received and that we're working on. It involves Medicaid identity theft. An individual called and said that she was contacted by the Area Council on Aging and informed that her application for utility and rental assistance had been approved. She said, well, that's impossible because I own my own home and I've never applied for assistance. She also went to pick up her medication, and a pharmacist asked her about the medication she had waiting for her at another pharmacy. Her doctor said that, her neurology doctor said, hey, I can give you that information about that medication that you were requiring and then her interaction with this other new medication that you're on. It's for bipolar. She said, I'm not bipolar, and I've never been diagnosed as bipolar. But there's medication that's being there, so this other person apparently seeing a doctor. She reported the occurrence to local law enforcement, who told her that she should contact us, which she did, thankfully, and informed her that he was the only officer in the area, and he was only part-time, so therefore he couldn't really help her with her identity theft issue. So we're currently looking at that as an investigation for medical identity theft. Appreciate your time this morning. I'd be more than happy to answer any questions.
All right, committee, are there questions for our Inspector General? Senator Fagg.
Thank you, Mr. Chairman. Thank you for your presentation. The three questions that you asked in the three different areas, how are those developed? Is that locally or is that a federal, and does that change very often?
Those questions do change, sir, and those are questions that that I come up with along with the staff. We discuss what we were trying to do on each audit that we develop. So it does vary from audit to audit, and there's no set guideline that's pushed to us, certainly not from the federal government. And as an independent office, we're the ones that typically come up with that.
Thank you.
Are there further questions? Representative Reese.
Just a point of or asking for a clarification. In your testimony, you have that the interim report revealed that an estimated 31% of Kansas school district employees provide Medicaid-related services, that their background investigation are not on file. Does that mean that it was never conducted, or it's just not on file?
We requested the records. They didn't provide them, and we assumed that meant they weren't on file. I will say that we had 4 school districts that completed the background investigations after we asked for the records. We could tell by the date of when the backgrounds were done.
Okay. But you've made an assumption that because it's not on file, that it wasn't done.
I agree with you. It's an assumption, but when you ask for records that they're required to provide and they don't provide them, I could say that they weren't done, but we didn't confirm that they hadn't done them, other than the fact they just simply didn't have them on file. So the assumption is, yes, they weren't done.
Okay, thank you.
Committee, are there further questions? I might comment, committee, on the CCRC issue. We actually have legislation that'll move through the Health and Human Services Committee, because what we discovered on that this last fall was the process goes to the insurance department, and the insurance department just kind of looks at it, stamps it, and it's done. There's no teeth in if someone commits fraud, and if I overstate or whatever, please fill me in. So we got to looking at it, and so I visited with the insurance commissioner, I visited with KDADS, I visited with the inspector general, and so what we've done is created a bill with all their help to move that from the insurance department to KDADS, and with the inspector general's help is to put some teeth in there should they falsely claim, because what we actually had was an individual that claimed they were in Kansas, but on their federal form said they weren't. So we'll have that moving forward.
Could not have said it better myself, Madam Chair.
All right, thank you very much.
I have one. I'm sorry.
Representative Ballard.
Thank you, Mr. Chair. I think you said you added bus drivers to your list that were not vetted.
That's correct.
Is that because it is not required that we have it, or is it because some districts do it and some do not?
Some districts do background checks on all their staff, others do not. And we were recommending that we think that all school districts should have background investigations, and we were just giving a list of people who we found didn't. Example, coaches, paraprofessionals, bus drivers, cooks. These are all people who may have independent contact with a student, and I think most people would agree that these are people who should be looking at. Just running a simple background check is it's not terribly difficult, and it would be that safety net to ensure that somebody who is a convicted felon or maybe has a background that would be inappropriate for them to have individual contact with children would be caught up, would be identified, and perhaps stopped from having contact.
Thank you for that response. Actually, it makes me want to ask why. Do my own school district have it as well? Because, how often do we read in the paper that an accident has happened with the bus or something has happened along those lines? And so in many ways, it goes even beyond just what happens internally, but in terms of, are they safe? Do they have a DUI? Do they have what kind of records or anything else? And I always thought they were required to be investigated. Okay, thank you. Thank you, Mr. Chair.
Committee, are there further questions? All right, seeing none, thank you very much. I appreciate it.
Thank you, Madam Chair.
All right, next committee, we'll start with our KDHE updates, and I don't believe the secretary's here yet. Is that correct? That's correct. All right, so Christine, you're going to start us off. Welcome to the committee.
Thank you. Good morning, Madam Chairman and members of the committee. I am Christine Osterland, Deputy Secretary for Integration and State Medicaid Director, and it's a pleasure to be here this morning. I'm going to cover Secretary Stanik's update. Oh, she is here. Look at that timing.
Sorry.
Perfect. And then we get her when she's out of breath, too.
Well,
so.
and Janet, if you're okay with her going ahead, and you can kind of, because I know what it's like when you come in running.
Okay.
All right.
I'll cover it. She can
You're
just
good.
answer questions, right?
That's why you have good staff.
That's right. Okay, so this morning, the first thing we want to cover is just an update on some changes that are happening within KDHE, especially as they relate to the Medicaid program. We've instituted what we refer to as the Medicaid Governance Committee. That committee is made up of Secretary Stanik, Secretary Howard, and myself. The purpose of this committee is to really work at setting a strategic direction and vision for the Medicaid program. We want to create a real good intake process to consider stakeholder requests, grant opportunities, CMS opportunities, and the like, so we can look at the impact to the program, to beneficiaries, to the state fiscal budget, all of those elements, and be able to look at all that holistically and set that vision for the Medicaid program. The committee will also provide final sign-off on any high-impact decisions. They could come from the clinical area, obviously our financial area, or our operational team. But again, to ensure that anything that has a high impact has been fully vetted and approved by both secretaries and myself. We'll make any recommendations to the governor's office as needed through the course of our work. And then aligned with that is we made some key organizational changes as we put this structure into place. The first change was my previous position as Deputy Secretary of Agency Integration was combined with the Medicaid Director position, so I cover both roles now, so it is one position instead of two. We created a CFO for all of KDHE, a Chief Financial Officer, and so he will have responsibility for all fiscal elements of KDHE, which would be Medicaid, public health, as well as environment. And then we created an external affairs manager for Medicaid, and that individual will be our primary contact with our stakeholders, will receive their requests, be their point of entry into the Medicaid program, will coordinate responses, meetings, et cetera. Next slide is obviously we are still in the middle of our MCO contract reprocurement. The bids were due to us on January 4th. We did receive 7 bids from proposed entities. Those bids are now under review. That review process will go until late February, early March. We're anticipating that we will begin negotiating with some or all of these proposed bidders starting sometime late March, going through about mid-April. There will be a bid protest period that is allowed by law. We're anticipating contract award again around mid-April. That will allow time then for contract signing and some of all of that legal work that has to happen, with our goal being that somewhere around May 20th, we will be able to, as the agency, start on implementation and readiness review. That is a very long and arduous process, and we want to allow ourselves as much time as possible, with a reminder that go live is January 1, 2025. Next slide. This is just an update. Obviously, for I think the little over a year now, we've been talking to the committee about the transition away from the big 1115 waiver. That transition did occur as of December 31st. And so on January 1, we were under kind of our new authorities. These next couple slides is just going to kind of do a summary of what does that really mean when we say we're out from under the big 1115. So what that means is we We still have an 1115 waiver. We call it a skinny 1115. There are 3 specific programs in Medicaid that we cannot operate either under a 1915B waiver, a 1915C waiver, or under the state plan. Those are our substance use disorder coverage, continuous eligibility, and some public health emergency related coverage because we still are in unwinding. So the only avenue for them was to continue under what we call a skinny 1115, but all of our managed care authority is now under a 1915B waiver, which means budget neutrality cap and all of the challenges that created is now behind us. The next page kind of talks about there were some elements of the 1115 that moved to the state plan authority. Just as a recap, the state plan is basically our contract with CMS that outlines how Kansas will operate its Medicaid program. It's very large and very detailed, but it really does outline everything that we must do as a state of Kansas to be in compliance. So there were some populations that moved away from the 1115 and under the state plan authority. You'll see those listed here on slide 6. American Indians, pregnant women, the healthy children under 19 years of age, breast and cervical cancer, and our medically needy population. And then kind of the last big element of this transition is we had a couple payment pools that were under the 1115 waiver HCAP and the uncompensated care pool piece of that, which is some payments that go to Children's Mercy and the University of Kansas Medical System. And then we had a large public teaching hospital, and you'll see a children's hospital pool. Those now are under what we call a preprint. It's a subcategory of the state plan, but it's specific to allowing alternative payments for specific purposes. So those programs were retained, they just moved authority. So that in an overview is what it means, the fact that we transitioned away from the big 1115, but that did occur. So we were very pleased to have that happen and meet that milestone. Next, we'll talk about the medically needy program. These first couple slides is just a recap of what we shared in the last few Bethel committee meetings around the population breakdown for medically needy, some of the populations that are covered. If you go to the next slide, this is a reminder that currently the medically needy program is frozen at $475 per household, which means once we determine what a household's income is, let's say it's $5,000, the family has to spend down to $475 in order to be eligible to begin receiving Medicaid services. We are one of the lowest states in the nation when it comes to what our current medically needy income limit is. We shared with this committee, I believe both in August and October, a concept around, instead of tying our medically needy limit to that old TANF limit, that we change it to something aligned with Social Security. We had looked at the Social Security threshold, which would raise it up to about $943 instead of $475. That proposal would have cost about $940,000 in state general funds. We've done since that time, we've continued to look at this. We have identified there are potentially 3 additional options that could be considered for the medically needy program. I don't have a lot of detail here. We're very close to having those finalized, but just kind of at a high level, what we're looking at is we were able to find out from CMS that if we do look at Social Security, we're not limited to the 943 as our threshold. We can actually use what they call the household of 2 size, which is $1,415 would be the threshold instead. There's an option to tie it to the federal poverty level. And then there's an option to do just an overall income disregard. The challenge with that option is we're not able to find an avenue where that income disregard could only apply to the medically needy population. If we go that route, it does appear that it would have to apply to anybody applying for Medicaid. So we are very close to having all of those options explored and solidified, and then we'll be creating a document that we will share with this committee hopefully in the next couple weeks, so you can get a look at what some other options may be to improve where our medically needy program currently stands. The last item kind of on the overall Medicaid before we transition to unwinding, one of the other endeavors that we're undertaking in KDHE is we're going to do a rate study for Medicaid. Some of our rates have benchmarks to Medicare, and it seems like that's kind of a one-for-one that, oh, you pay 80% of Medicare or 50% of Medicare, but in some service areas such as outpatient hospital, Medicare and Medicaid do not reimburse the same way. We may reimburse on a claims or a code level. They may bill on a payment grouping level. And so you really can't do a one-for-one comparison. So we've decided to look at doing a rate study, so we will compare all of our rates to Medicare benchmarks, and that will mean if Medicare pays differently than Medicaid, it's doing that, breaking that down, doing that crosswalk, and giving us that real comparison of how we look compared to Medicare. For things that do not have Medicare rates, dental is a great example. There is no Medicare benchmark. Being able to do benchmarks to American Dental Association or other appropriate entities so we can give, again, some level of gauge of how our rates compare. We're going to look at how our rates compare to other Medicaid programs across the country. Looking at, again, are we, average, below average, above average? We're going to look at our unique payment methodologies, DRG. There's several state Medicaid programs that reimburse in a DRG methodology. How do we compare? Those are difficult things to tear apart and kind of come to a conclusion, but we're going to ask that be done. And then we're also going to look at various state laws and regulations. One of the things that we've been hearing from some stakeholders is, for instance, Kansas may have a requirement in state law particular to a birthing center or a particular provider type that means they have to have more staffing or they have to do something extra, which is additional costs. So if you look just at rates, we may look comparable, but if you bring into the fact what regulations are in the state, is that rate sufficient? So it's going to be a pretty broad study. We will be sharing all the results with the legislature. Our goal really here is, as we look at rate increases, that you have a lot of data and information to make really good decisions and, really be able to identify maybe rates we need to focus on, which ones seem to be, pretty well set. But again, will give us a better holistic view of where our rates are now compared to other state Medicaid programs or other benchmarks. With that, that's kind of the end of kind of the first update. The next set of slides are the standard slides that we do, Madam Chair, that we do every Bethel. If you want me to walk through those page by page, I'm happy to, or we could just go on to unwinding and do questions.
I think we can go to questions at this point.
Okay.
All right. Committee, are there questions? Representative Carpenter.
Thank you, Madam Chair. And I warned you that I was going to have a lot of questions about this, so I didn't want to blindside her. So, but I do have one. I see the 475 now. So is that a monthly rate? Explain how that works.
So what happens is it's a 6-month window. And so what we do is, let's say that your spend down, when you compare your income down to 475, that differential is $1,000 a month. I'm going to go low. You times that by 6, your spend down is $6,000. So once you hit then that threshold, you've spent down $6,000, then you're eligible for Medicaid for whatever period of that 6-month window is left.
Madam Chair. So when you say spend down that to that 475, what would be the spend down for?
It's medical services. Okay. So yeah, so you could have an instance where you go to the emergency room. Obviously, you're probably going to meet your spend down immediately and then some. But yeah, any medical service, prescribed drugs, doctor visits, inpatient hospital, but it's medical services that you're spending down to reach that threshold.
So you'd have to spend down $7,500 basically
Yes.
in medical expenses.
Medical expenditures
To-
and yep.
Okay, very good. Thank you.
Committee, are there further questions? I guess I'm a little bit lost on the $6,000.
Yep, so what happens is when we calculate the spend down, we look at where your monthly income, because Medicaid really looks at monthly income. So let's say your monthly income is, like I said, $1,000 above the 475. So I'm gonna do math in my head, so that would be $2,475. It's not my strong suit, by the way. So what we're saying is you're $1,000 a month over Medicaid limit. Because we run medically needy on a 6-month window, the reason we do that, some states do it month to month, but what that really means is I might hit it this month, I may not, but then I'm basically on, I'm off, I'm on, I'm off, I'm on, I'm off. So what Kansas did is said, we're going to do this over 6 months. And at whatever point in that 6 months, so we're going to take your monthly, we're going to times it by 6, so that $1,000. So in that 6-month window, your spend down is $6,000. And so yes, it means it's higher to begin with. But a lot of these folks are very catastrophically ill, cancer patients, organ transplant patients, patients that have pretty catastrophic medical bills. But when they hit that 6-month spend down, then let's say they hit it in month 2, then they get 4 months of guaranteed Medicaid before they have to start over and do this all over again. If they hit it in month 3, they get 3 months of coverage. But it was a way to kind of try to stop that on, off, over the course of a year and give them hopefully longer periods of time where they're covered before they have to start over.
All right, committee, are there further questions? Representative Carpenter.
Just to clarify then, so it doesn't go backwards to cover medical expenses?
It will go back to, so if let's say you qualify on June 21st, it's going to go back to June 1. Now, if you got on medically needy, 2 months ago, but it will always start at the beginning of the first of the month. I'll just say it that way.
So halfway through that, you incur and meet your spend down. It doesn't go back. If it was a $200,000 bill for a surgery or, who knows? It doesn't go back and cover any of that. Is that correct?
Yes. So what will happen is the provider will wait and bill at the point, let's say you do an emergency room visit. And, well, that's not a good example. Let's say it's month 2 and you do an emergency. I'm trying to think of when that would really apply. Really, only time that would apply is inpatient hospital. Because I'm trying to think, if you were in month 2 and you went inpatient, that inpatient stay starts that month. We're going to retro your eligibility back to the first of that month, so that bill would be covered. Now, what we do know is that some providers, like for instance, a pharmacy, let's say your total pharmaceutical bill for the month is way over your spend down. They'll wait and bill that once you hit your spend down. But again, it's because if you have that high of a medical bill, what may not be paid is some physician visits, but any high-end medical bill is going to be within that window.
Okay.
Because you're going to have to go to the hospital, and then you'll meet it, and then it's covered because it's within that month.
Thank you.
Yeah.
Thank you.
Committee, are there further questions? I might just make a suggestion as you're looking at the dental, and you said there wouldn't be a comparison between Medicare and Medicaid. If you look at Medicare Advantage plans, you will find dental out there.
That's a great suggestion, and that's why we want to do this rate study, is to find out where all those benchmarks are that we could use that might give us a point of reference. Because yes, some of these services, it's hard to find that. Excellent suggestion.
All right, committee, seeing no further questions.
Okay.
All right.
So if we go to slide 20 in your, I believe it's slide, oh, I see the numbering is off. But much further back in your packet is where we start the unwinding update. Just, again, we'll go through some high-level updates of where we are with unwinding. The first update, the slide is titled KDHE Staffing Update. It looks like this for those of you that are trying to go through the packet to find where I am at. This is just a look at where we are with our staffing levels. Right now, we're at 89% of our positions are filled. Kind of what that means is for eligibility workers, you can see there that we have 29 eligibility staff vacancies and 2 supervisor vacancies. So again, not terrible. We like to be more, having about 92 to 93% of our positions filled, but again, not real far off. Next slide is titled Current Unwinding Data, kind of a look at where we are. So as of January 4th, kind of where are we with unwinding? We have sent renewal notices to 467,818 individuals. So again, we are getting well to the tail end here. We've approved about 46% of those, or 214,000 members have been approved. About 11%, or 53, just a little over 53,000 of those folks have been discontinued. Discontinued means we actually processed their renewal and we determined they no longer met the eligibility requirements. We have about 222,500, just shy of that, individuals in their reinstatement window. That's about 5% of the population. That reinstatement window is once we discontinue you, you have 90 days. We call it information received on denial. You have 90 days to submit whatever's needed, and if we approve you, we'll backdate you way back to when you were discontinued, so it'll look like no break in coverage. And then we have about 57,000 individuals, about 12%. Those are folks that had their Medicaid inundated. They're past that 90-day window, and what that means now is they cannot go through the renewal process. They would have to submit a new application in order to be considered for Medicaid eligibility. We are now at the end of the 12-month cycle. Actually, tonight, we will generate and run our final unwinding renewal batch. So we are now starting the mailing for month 12. What that means is in March, when we run our renewal process, the volume should go back to much more pre-PHE levels, because we will have done we will have covered all of the unwinding population. So really, it's not a lot of change. It's really more of a volume change for our eligibility workers, as we'll be sending out far fewer notices. Where we are with discontinuances, we have only run discontinuances through the month of October. They lag a few months behind. Some of that was, as you remember, we've talked about Postal Service delays and folks didn't get their packets. We did a delay in discontinuances. CMS asked us to delay 1 month as we switched to what we called individual versus household ex parte. So there's a little bit of a lag between where we are with discontinuances, but we've run through October. So we are actually getting to the end. The next slide is just our update on our applications, kind of a reminder where we are in our yearly calendar. On top of unwinding, we just finished the federal marketplace open enrollment. As a kind of a reminder to the committee, open enrollment about doubles. It either is just below double or just below double or just above double, depending on the year, our monthly intake of applications. So it was kind of like a double whammy, because we had our unwinding renewal population, which is, again, about triple what we were seeing pre-pandemic, and then you put on top of that double the intake of applications. To say that we're kind of have a lot of work in-house is an understatement. So we right now have just under 22,000 applications in-house. We have 1,798 applications over 45 days, which is about 8% of our total application volume. Again, to put that in perspective, right before we went into the pandemic in February of 2020, we had 1,300 applications over 45 days. When I first reported on Unwinding, I believe that was June, Bethel, we had just over 2,000. So even with the uptick that was caused by the marketplace open enrollment, our staff has been able to keep our over 45 in a good spot. And as I've told the committee before, over 45 will never be zero. There's just reasons and legitimate reasons why cases can and do age. And again, we are looking forward to next month when we're past some of these historical unwinding volumes so we can kind of get back to business as usual, if you will. Next slide is just a look at the call center. I think you all remember when we first started the unwinding and we got to the end of April, there was an absolute onslaught of calls that hit the clearinghouse. I know some of you were hearing complaints about wait times and the like. And again, this is just a look at that since August. Our vendor Conduit has been performing very well in the call center. Our abandonment rate remains very, very low. Our average speed to answer remains very, very low. So again, as they made a lot of adjustments with the early uptick in calls, you know, we've been able to be very steady. And I am happy to report that there are a lot of states that can't say that about their call center. So while we're not perfect by any means, I think we've made a lot of adjustments to ensure that our members have access to our call center when they need to. And with that, that is the end of the unwinding update and kind of the Medicaid portion. I'm happy to stand for questions.
All right, Representative Carpenter.
Thank you, Madam Chair. So Christine, where are you at on long-term care eligibility?
So I believe
there wasn't a sheet in here, was there, or did we?
Yeah, it's caught up in the data. So long-term care right now, over 45 that are ready for us to process is 232 cases. Over 45 of cases where we're waiting on information is 246. So really nothing we can do with those. So there's 232 that we can take action on.
And you're fully staffed, or pretty
close.
Pretty close to fully staffed in there. And so do you expect that to go down?
Yes. Our goal, and I'm going to turn my head so Yvonne, if I misspeak, you know, she can jump in because Yvonne's our Director of Operations. Actually, next time she gets to present on Unwinding. I gave her another break since she's only been here 6 months. Our goal is once we get through Unwinding and we're back to steady state, we'd like to see the total long-term care over 45 to be around 250. So that would be both active and pending. So that means, yes, so we'd like to get it down a little bit lower. You know, some of that will depend on Social Security and some other entities external to us because we're dependent on them to make final determinations. But that's really where ideally we'd like to be.
Okay, very good. Thank you, Madam Chair.
Okay, good.
Representative Gossage and then, or Senator Gossage, I apologize, and Representative Reese.
Thank you, Madam Chair. Quick question. Are we tracking how many of the people that were found to be ineligible for Medicaid that enrolled in the exchange in the federal marketplace?
So we know how many of those that we transferred to the marketplace. We don't get the return data then to know how many the marketplace or they actually either completed that process or actually got enrolled. All we can see is what we send up to them. Now, I know the marketplace is doing some reporting on their own, but it doesn't tie directly back to, you know, like Kansas Medicaid sent you this many and now this many are covered under the marketplace. You can make some assumptions from the data, but it's not a one-to-one comparison.
Thank you. Thank you, Madam Chair.
Representative Reese.
Thank you for the report. I got distracted and so I'm going back and looking at the slides. Do we have any information regarding the unwinding for those that are on all of the waivers and where we are with them? With
yes.
The reinstatement?
Yep. So actually one of the things that I think, and I think we may have touched upon this in a previous Bethel, but some things kind of run together in my mind. But as we started the unwinding, HCBS became a population that became very apparent that kind of the clearinghouse model that we have for eligibility wasn't perfect. And so Yvonne and her team and Michelle and her team at KDADS have been looking at all the people on the waivers that lost eligibility, trying to go back and make sure, it was a legitimate, reason. And what we found, and unfortunately, again, hindsight 2020, those stimulus checks. A lot of people that received those, they put them into bank accounts, and that put them over resources. And so what they had to do was basically go, and there's some ways that you can get that out of your bank account. And we were able, in many cases, to backdate those folks. But again, we've definitely learned some lessons. We also did, I believe it was in December, the training, was the training in December for the, yeah. In December, we had about 70 HCBS providers, and we did a training for them on the whole renewal process, how they can help, how it works, information we need, again, with the goal being that we can do a better job of helping this population, because they don't have the liaison program like we did for nursing homes. And I think we've identified a gap there that we're trying to work with KDADS very closely to shore up, and the providers. And I think it's getting better, but there's definitely been some lessons learned and ebbs and flows with that population, and unexpected, like, again, the stimulus checks just, to be honest, it until it happened, then it was like, oh, well, yeah, obviously. But, again, had we known that before unwinding, we may even could have done some communication, to let folks know of the, the impact.
So there is data that we can look at, or no data that we can look at?
Yeah, I think, Yvonne, do you guys have it broken down for each waiver? Yep, I thought they did. I thought we had that, so I'm, always going to check with my expert over there. But yes, we can get you data on for each waiver how many folks have lost eligibility. Because we've been looking at that, trying to understand it, and
that.
yep.
Thank you, Madam Chair.
Committee, further questions? All right,
All
seeing
right,
none. Thank you
thank
very
you.
much. So now who do we have up next
I
then?
think it is, Ashley, are you presenting? Yeah. Yes, Secretary.
Is anyone going over the KanCare members' expenditures and capital or capitation payments?
I mean, we can if you want. Those are some of the standard updates. There's, there's not a lot, difference.
No, we're good. All right, thank you very much. Next, we'll have Ashley Goss with KDHE. Welcome to committee.
Good morning, committee. Thank you, Chair. I'm going to give you a brief overview of immunization, kind of our Kansas law around immunizations at the request of the chair. So I'll go through these fairly quickly, and Dave, I'm afraid to ask about slides. Do they have them in their possession? Oh, look at that. See, we did it this time. All right, so we'll touch on relevant state statutes, school and daycare requirements, college requirements, and then briefly about the business requirements. So next slide. There you go. All right. So our relevant state statutes here are listed that we'll talk briefly about. This just gives you a description of where schools fall, where their statutes set, requirements and allowable alternatives, exclusions, and then what the statutes are around colleges and universities. Next slide. So KSA 7262 requirements are listed here on this slide, and this is the statute that states that upon enrollment and prior to admission and attendance in a school or a daycare program operated by a school, documentation should be presented that the child or the student has all the required vaccinations. If they do not, then the reason is given as to why, whether it's a medical exemption or a religious exemption. Next slide. 72-6262 talks about the two exemptions that we do allow in Kansas. In Kansas, we have a standardized form that providers should use to ensure appropriate documentation of all required elements. The standardized form that we're talking about here is for medical exemptions only. This is a form that the caregiver or a parent guardian can take to the doctor and have the physician fill this form out to justify the medical exemption. And then a religious exemption is, there is no form, there's no formal form at all for that. That can be written and provided on whatever documentation the caregiver chooses to provide. And just for your own knowledge, the KDHE does not collect these. We do not store these. We don't want them. So the schools and or the daycares are the ones who would keep these in their own files. It is not KDHE or the local health department. So it's at the discretion of the provider, whether it's a school or a daycare center. Next slide. As you will see on this slide, you'll see the currently listed in the Kansas Register what the requirements are for schools and daycares. The vaccination age and number of doses is according to the ACIP guidelines. These are the only ones currently that are required, and I say currently, we have not added anything to this vaccination list since 2019, and that was when we added hepatitis A and meningitis. And prior to that, nothing had been adjusted since 2008. And one common question we get about this is, are you planning on adding anything to this, such as COVID or flu? There are absolutely no plans to add either of those now or any time. These are the recommended required vaccinations to enter school and daycare. These also are the vaccinations. One reason why the ACIP recommends them is because these are the ones that would require a very significant response because of the severity of the bacteria associated should you contract one of these. Next slide. This is also something else that gets rather sticky, and it was actually in the media over the summertime in one of our counties. So school boards make the decision to adopt a policy to exclude children who are not in compliance with the immunization requirements, meaning they're not up to date for the requirement or they don't have the required exemptions listed. I cannot stress enough that this is totally in the school board's hands. KDHE has nothing to do with this. We cannot call a school board and say, let this kid go to school. Most schools will set a policy that's normally about 6 weeks after they start school. Each school can do their own thing. I'm saying the average is about 6 weeks for after school has started. You have this long to get your child either up to date with vaccinations or provide us a reason for exemption, so medical or religious. And then after that, if the child has not met those requirements, the school then can exclude the child from school, again on the school board's terms, not KDHE. This is not governed at all by KDHE. This is all at the discretion of schools and daycares. Next slide. This slide just talks about, again, what we've kind of already talked about, the number of doses. So in a daycare or child care center, they are required to keep on file that they have the students or the child's immunization records, and they should be able to produce them upon survey. This is to ensure that the kids are compliant either with exemption status or that they actually have the immunizations. Same process for schools. Next slide. Now this slide, most of this information you can find on our website. We pulled this directly off of our website so that you can have a visual of what the exemptions look like in the state of Kansas. Blue is the medical exemption, and as you can see, it's stayed rather flat over the years. Religious exemptions have gone up, which has increased the total over the years as well. Next slide. And our overall exemption rate right now in Kansas at the kindergarten vaccine coverage is what we're looking at is 2.89%. Still pretty low, but it has crept up since 2010. And next slide. KSA 76761A talks about colleges and universities. Very similar to school boards, college and universities do set their own policies and enforcement for vaccines that they require to be on campus. And generally, these are just for the students that reside in student housing. But again, this is at their discretion. It is not at KDHE's discretion. We cannot force a university to either include or exclude. Those are their policies. And final slide. Final slide is really addressing businesses such as healthcare facilities. So during COVID, I'm sure we all heard, and I'm sure many of you received phone calls from your constituents, specifically maybe healthcare providers or those that work in health facilities about, do I have to get a COVID vaccine? KDHE does not set requirements for businesses to and including health facilities. The only way that a health facility would have a required immunization policy is through CMS, and that is only if that health facility receives CMS payments. So they are certified by CMS and licensed by CMS. We are the surveyor on behalf of CMS, KDHE is. So if we were to go into a health facility and they have a policy, if they develop their own policy, there's not even a CMS requirement, but let's say a hospital says, we require all of our employees to have a flu shot by this date, to have a TB skin test by this date, then we're looking at the compliance of their employees. So we're looking for the record to show that they are indeed following their policies and procedures. Again, KDHE does not set for any local business of any kind, including health providers, what the required employment opportunities within their agency. And that was super fast, Chairwoman, but I am happy to stand for questions.
Committee, are there questions for Ashley? All right, seeing none, thank you very much. Christine, Representative, or excuse me, I apologize, Beverly. Senator Gossage, do you need this chart?
Thank you. That's okay. I've called her senator plenty of times. We're just so used to saying that in our chamber, it makes it hard to go back and forth. So when I'm looking at individuals sent a renewal notice, so the 467,818, I'm assuming was the population on Medicaid at the time before we began the unwinding.
Yes, this information would have, sorry. Excuse me. So that information would have been as of December 31st, so the first part of January. When we went into the pandemic, we had about 540,000 on Medicaid. And so, yes, the 480,000 is because at the end of December, we would have had the January mailing, which is for the February population, and now we have the February mailing for the March population. We had those 2 months left. So yes, that number is very close to being what our total population was going into the unwinding, but the variance is just we had at that point 2 months left of mailings to do.
So you're saying the 460,000 had received the mailings, but you had 2 more months that had not received the mailings?
Yes.
So that would explain why you're telling us that we cannot have the total number left on Medicaid for 2 more months because you're running 2 months in arrears.
Yes. So that data runs a little bit behind. So what will happen is, as we look and want to see what totally happened during the pandemic or the unwinding, so we will send the last mailing out February 2nd. That population will not actually come off of Medicaid if they don't respond to their renewal notice until probably end of May, so June 1. And then they'll still have a 90-day window to supply the information and be backdated. So there's always a lag. Now, with the fact that we're 10 months in, probably by the next Bethel, we'll be able to give you a really good, pretty accurate. There'll be a little bit of variance, but we could probably give you a very good look at what happened, where we started, how many people have, are no longer on Medicaid, how many were, discontinued. And those buckets, while there'd be some variance, because we aren't going to be all the way done with the cleanup, but we'd probably be close enough that I would say it's probably going to be about 80%, maybe 85% accurate.
And so at this time, do you have a feeling for, because I'm trying to add up the percentages here and add up your numbers, do you have a feeling for how many people that are still receiving services today?
So we are tracking, again, it's a little bit hard with these lags, but when we look at it, when we were going into the unwinding, we really thought that we would go back to be around 410 to 420,000 on Medicaid, which was similar to where we were entering the public health emergency. We're tracking to be pretty close to that number, so I would anticipate, by the time we get, into the summer months, that's where we're going to see our enrollment at. But again, as we go into Bethel, we can kind of give you that trend of where we're tracking. But when we've looked at it, that's what we're seeing, is that we're probably, though our early projections, to be honest, because it had been 3 years since we got income data, was really a pretty educated guess, it does seem to be holding fairly true, which of course will mean about 110 10 to 120,000 individuals will have lost coverage.
And one last question, if I may, Madam Chair. So this entire time, the MCOs have been receiving this monthly capitation for each of the people that have stayed on Medicaid that have not come off. Can you tell us how much that amount is per month?
I can get that to you. Yeah, what we've been paying each month, because obviously it will fluctuate as each month goes by as people come off the rolls. But yes, we can get that to you.
Per individual. Thank you
Yep.
very much. Thank you, Madam Chair.
Yeah, just make sure you send that to Dave so the full
Yes.
committee can
Yeah.
get it. All right, thank you very much,
All right.
Christie. Oh, Representative Carpenter.
Thank you, Madam Chair. I'll try not to monopolize your time. So there was a $52 million caseload increase for EPS. So diagnostic for kids that are not on the wait list. What are you planning on doing with that?
So that, so just for the rest of the committee, so the state of Kansas was given direction by CMS that we were not correctly applying, it's called an EPSDT requirement, and EPSDT is early periodic screening, diagnostic, and treatment, I believe, if I have it right. But essentially, what that requirement is any child is eligible for any medically necessary service. And if that service is medically necessary, regardless of whether it's in our state plan or not, we need to provide that to that child. So and this predominantly applies to waiver services, though it, in theory, is a little bit broader than that. But up until that point, or currently, PCS services, personal care services, and like private duty nursing were only provided to waiver children. They were not a state plan service for the general population. Per the CMS guidelines, any child in Medicaid, so any child on the wait list that's Medicaid eligible, any child just in Medicaid that's enrolled is eligible to receive those services if they're medically necessary. So what we did is we looked at the waiver population as our proxy, and then we tried to estimate how many children on the wait list, because obviously we know that's where probably the bulk of the spending is going to come from. For each of the waivers, how many children in that waiver, is it 50%? Then I think most of the waivers, that's where we ended, that 50% of the children on the wait list would receive, like personal care services, what obviously the rate we pay or what we pay for private duty nursing, and we tried to come up with a fiscal, which ends up being about 51 million, I think just shy of 51 million for fiscal year 25. But that's where that's coming from, is that now what we don't know, and I think where the risk is that since we've not done this before, how many children that aren't on the wait list that might, let's say, have a bad car accident and they've got both legs or in cast and they might get approved for personal care services for a short duration of time. There's going to be an aspect of unknowns here, but we do believe we've captured probably where the vast majority of these costs will come from, and that's what that fiscal represents.
Very good. Thank you for that.
All right, thank you very much, Christine.
Thank you.
Appreciate it. Okay, and I believe, because we are running early,
You
can ask it later.
Yeah, I can ask it later.
All right.
Thank you.
Okay, we're running early, so we're ready for KDADS, and I know that the secretary is not here yet, so Scott Bruner's going to lead off. Thank you, Scott.
Madam Chair, members of the committee, thank you for the invitation. I'm not Secretary Howard. I'm Scott Bruner. I'm the Deputy Secretary for Hospitals and Facilities. Secretary's otherwise engaged with your colleagues in the Joint Committee on Rules and Regulations. So I'll kick off our presentation. You should have some slides in front of you.
Where are you going to start here? Are you going to do the secretaries as well, or?
Yes.
Okay, so we're going to start at the very beginning. Thank you very much.
I'm going to do it in my own voice, so hopefully that won't be too confusing.
Do not try to imitate the secretary.
That wasn't even on, not even on the list. We did want to announce some organizational changes that we've had at KDADS, not entirely new, but things we did want to make the committee aware of. Andy Brown, who was our Commissioner for Behavioral Health Services, has been promoted to be our Deputy Secretary for Programs. For those of you that have been on the committee for a while, Janice DeBoer, before she retired, was the Deputy Secretary, my counterpart, that oversaw the programmatic side of KDADS, behavioral health, long-term services and supports, aging programs, and Andy's taking that role, which I'm really excited about. That
Why don't we
he's
go
there.
ahead and have Andy stand up so everybody knows who he is, I believe. Or did he
He's
just
over
step
at
out?
Joint Rules and Regs. I feel the support, whether he's in the room or not. It's great to have him in that role.
Well, he left the better part besides you. There's someone behind you, so go ahead.
That's true. That's our other update. Drew Adkins, who was the Assistant Commissioner, has been promoted to Interim Commissioner for Behavioral Health Services, and he'll do the behavioral health update today. And then finally, we are in the process of recruiting for an Aging Services Commissioner. Our aging programs, it's in our title, and they're part of the Long-Term Services and Supports Commission today. But the Secretary would like to elevate not just the funding, the services, the programmatic side of our agency in services for seniors. So we're looking for a commissioner to really give that area some more additional focus and attention. And when we get that person appointed, we'll certainly let you know about it, and they'll be part of this update going forward. The other update that the Secretary was going to provide was about the Regional State Hospital, which is my project, so it made sense for me to just continue on with that. You've asked for an update about our regional state psychiatric hospital in South Central Kansas. So I have a couple of updates about that. The governor did appoint an advisory panel to help with that project over the summer. We've met 6 times since the panel was formed. And one of our first tasks was to generate an interim report to the legislature and the governor in January to kind of capture what work we've done and any recommendations that the panel wanted to advance related to developing that state psychiatric hospital. The discussions have been really robust. The membership of the panels worked really hard, brought great perspective both from the county, programmatically from the county government side. Representative Carpenter's on the panel as well as some other legislators. We've had good discussions, and it's been a really important part of our development of the project to have them involved. But in that interim report, there were 2 recommendations from the panel. The first one was that Governor Kelly and the 2024 legislature should include funding in the budget for 2025 to allow us to construct an additional 50 beds as part of this project for a total of 100 beds for adults with acute mental illness or criminal defendants requiring competency evaluation or treatment. KDADS, in that recommendation, was asked to provide an estimate of the funding needed to construct and operate the full 100 beds before the 2025 budget is approved. The other recommendation that the panel made was to update the executive order that created the panel and authorized it. I think in the development of that executive order, as it took some time, we set target dates for work products throughout the life of the expected life of the panel. And one of those was a final report that would be due in June of this year to advise the 2025 legislature about any changes that might need to be made to create this hospital and give it authority. We've got some more work to do. I don't think we're going to be done by June to be able to have those recommendations in place. So we're going to ask the governor to extend that deadline more to the end of the year. It'll still be for your work for the 2025 legislature, but we just need some more time to do the writing and do the thought around that. The report, which we're happy to provide to the committee, also laid out some of the work efforts of the panel for the next year. We're going to look at workforce issues in the area for recruiting and retaining and trying to figure out how we staff this hospital and other behavioral health service providers in Sedgwick County. We're going to talk about privatization options for this hospital, what that might look like and things to consider. And then finally, there are some statutory changes that we think we will need to make to open the hospital around identifying a catchment area, naming the hospital, creating it in statute so it can get funded and have a budget. And we'll bring those recommendations back, or our plan is to work on those recommendations and bring those to you for the 2025 session. On slide number 4, the other significant update that we wanted to provide was about the site selection for the regional hospital. This slide's a little bit dated since I wrote it, but so we did have a town hall meeting in December in Wichita to gather community input on 4 potential sites. Sedgwick County, working in our partnership for construction and building the hospital, did a request for proposals for either property or buildings for the hospital site. There were 14 total proposals submitted. A team of Sedgwick County staff and myself and some of my team reviewed those proposals and narrowed it down to 4. We shared those 4 sites with the public and gathered input about which they thought the public thought would be better, the best site for the hospital given what the proposed use is. We gathered that information, we shared it with the advisory panel, shared it with the governor's office, and kind of used all that to arrive at a recommendation. We have since, I wrote this slide, we advanced that recommendation to the Sedgwick County Commission, and they authorized us, the county staff, to pursue working on a purchase agreement for a site for the hospital. It's at the corner of MacArthur and Meridian, south of 235 in Wichita, so it's on the south side of Wichita. It's an empty property at the moment. There's nothing on it currently, so it's a greenfield site. We've had the county commission authorized that action last Friday, and we've done some public announcement around that. We've had an initial conversation with the property owner and starting to work on the kind of what that agreement's going to look like to get that underway, but that's moving along. So there is a site now that lots of people have been curious about. We are going to do some additional public outreach, both from the county commission and legislators from the area, again, are supportive of the project, supportive of the location, but want to make sure that we're listening to folks in the community about their concerns, what issues they might have, and other thoughts that they might want to bring to the project. So we're going to have a town hall meeting specific at South High School February 26th, that's the Monday, to just give an opportunity for folks to come and ask questions and gather some feedback there. We'll probably do more of that as we get the design finalized so people can actually see a rendering of what the building would look like on that site and give us, that makes it more real to react to in terms of the area. The other thing the county commission has done is moved on December 20th forward with a contract for an architectural firm that's going to do the design of the building and get us through the construction documentation process. And we've had an initial kickoff meeting with the architectural firm to start working on that and plan out the work to get the design done over the next 16 weeks or so. The goal of that is to get the design completed so they can translate it into documentation, construction documents that general contractors can look at and give us an estimate of what it would cost to build, and then we can get that contract awarded as well sometime in the fall with the hopes of breaking ground by the end of the year or first part of 2025. And finally, we're still working with the county on the ARPA agreement to transfer the $25 million of Spark funding that's been authorized for the project to get that to the county for the construction process. Those agreements, the 7 or 8 that we've done, they take a long time to negotiate. There are a lot of requirements for ARPA Spark funding that takes some time to negotiate. I don't think we've had any significant delays. We've learned a lot about the process, but we've made good progress on it, and we'll certainly get that in place here in the next 4 to 5 weeks, I think, and then that'll keep the money flowing so Sedgwick County can keep working on the construction side of the project.
If it's okay with you, I think what we'll do is we'll just go, as you go through the sections, we'll ask for questions.
Okay.
Are you good with that? So are there questions on the new facility? So are you saying at this point here, at the stage that we're at, is the site that the county has selected is the site? There's no possibility of any other site popping up on us?
Not that I'm aware of. We haven't formalized a purchase agreement for the site. We are working on that, but that's our intent to close on the site that we've selected at MacArthur and Meridian.
All right. Any other questions, committee? Representative Reese.
Thank you, Scott. Are there plans to involve stakeholders in the design of the building? Locals?
A lot of the, we will. It's probably more of the, how the design and building will fit into the community. There's not a lot of development immediately around the site, so we're kind of in a fresh area. There is some residential, a few homes to the west. There's a couple of churches that are adjacent to the property. So once we have something more to look at, I think that'll be an appropriate time to say, here's what the design is going to be, what the building's going to look like, the exteriors with, you know, the fencing options and landscaping, things like that, and get some feedback about that. In terms of a lot of the design, just in terms of the total amount of work is what the inside of the building is going to look like, how it's going to flow, safety factors for staff and patients. So I don't know there's as much of a need for that, but the public parts of the building, we certainly want to get some feedback on, and we've got time in the schedule to do that.
Thank you, Madam Chair. I know there are architects that are very in tune to designing buildings such as this for psychiatric facilities that are much more trauma-informed care in their design. Is that going to be a goal?
It will be. It certainly is for us. The firm that's been selected has some experience, has a great deal of experience in building behavioral health hospitals, facilities that serve behavioral health populations and using trauma-informed approaches. So we're really comfortable with the firm that's been selected in terms of their experience, and they've brought some other consultants into their into the project as well to bring some additional perspectives on those kinds of factors. That's certainly front of mind for us.
Good, thank you.
Representative Berquist.
Just a simple question. You may have already told, but which corner of MacArthur and Meridian is it? Is it on the south side west, or?
It's the northwest corner of MacArthur and Meridian.
Northwest. Okay, thank you.
There's a quick trip on that same corner, and it's the property that extends to the west and north of that quick trip on the corner of MacArthur and Meridian.
Thank you, ma'am.
Senator Fagg.
Thank you, Mr. Chairman. Scott, thank you for your presentation. You said they don't have a purchase contract on this yet, so I guess the guy that owns the property probably knows where you're wanting, and I would think that would affect your purchase contract. You might comment on how that process works.
I'd be happy to. So this site in particular, a purchase agreement is wrong because in the offer, or in the response to the county's request for proposals, they've offered this site for free. The owner is donating the property to us. There are some things to still negotiate about how the infrastructure on the rest of the site is going to be developed, our access to the site from primarily MacArthur, utility easements and things like that. So we're not negotiating a price. We are negotiating factors related to the site and how it fits with the other development that's planned.
Committee, further questions? All right, seeing none, proceed.
I feel like that was a really straight response, but if it wasn't clear enough, I'm happy to go into more detail. But we're not buying anything, so we're negotiating other factors related to the site. But thank you for the question. I'm going to continue talking about state hospitals. We looked at the length of our slide deck and thought there are things that we can probably skip through or just point out what's in the slides, and you can look at it at your leisure and focus on some more important topics. But so for the state hospitals, I've been providing an update on our number of direct care vacancies and percentage of vacancies over the last several meetings, and the charts are in the slide deck for you. Again, I won't say too much about that, with maybe one exception on the slide number 7 on the vacancy percentage. KDHE, our facility for folks with intellectual and developmental disabilities here in Topeka, there's been a little spike in the percentage vacancy rate. That's because we found about 80 positions that weren't part of the report before this date. So it's an instrumentation problem as opposed to anything that's actually going on that's significant. But and rather than repost it all the way back to 2021, we just are going to show the blip. I'm going to take time to explain it and then move on from there, but you'll see that going forward. On slide 8, the state institutional alternative hospitals, these are community hospitals we partner with to provide state hospital level of care. We've updated the utilization information there. And slide 9 has the map of where those are located. And the one significant update there is Hutchinson Regional Hospital is on the list. At the bottom of the list of hospitals that we're partnering with, they're in the enrollment process. They've completed contracting with all of the managed care organizations, and the last update I saw was they're planning to start admissions in SIA beds either in April, mid-April or May. So we'll have some more information from them as the next time that you all meet. The next section of the presentation about state hospitals talks about lifting the moratorium at Osawatomie and just giving you an update on where we are with that. Again, we've lifted the moratorium. We can take voluntary admissions when our census is low enough, and that hasn't been the case for quite a while. On slide 11, the other significant activity at Larned is the remodeling of the Biddle building, which will let us open up 12 additional beds. That's moving along. We're expecting the construction to be complete in February. We're going to hopefully get it occupied, actually move patients in there a little bit later after we get the construction done. A couple of little hiccups, but nothing that's significant other than it impacts the timeline. But when that's available, then we'll move all of the patients from the existing Adair acute units to Biddle, move all the staff, move all the equipment, and then use the Biddle building. What's important about that is it's 42 beds. They're all single occupancy, so we can use every single one of those rooms all the time, as opposed to having 60 rooms that are double occupancy, and then when we have a patient that needs their own room or can't be with somebody else, we're fighting against our vacancy rate. So that's the OSHRA model part. Slide number 12, mobile competency. Again, we've been providing an update over the last couple of meetings about our efforts to try to work through the competency wait list and wait time at Larned by working with local partners. So on slide 12, this represents our staff from Larned State Hospital that are doing competency in jails. And you can see in November and December, we completed 5. That shows you all of last year and how many we've completed. We've got pilot projects in Shawnee, Wyandotte, Sedgwick, Douglas, and Leavenworth counties, both to primarily do evaluations, but we are doing some restoration in those jails as well. Reno County is working with Horizons Mental Health Center to get some orders amended so that Horizons could complete the competency restoration for 2 individuals in Reno County. Douglas County is moving forward. Again, it's small numbers, but to have the partnerships in place is really the instrumental part, and we'll see what the progress looks like that as we prove this works as a model that we can, where we've got defendants that can be successfully restored in the jail setting. We'll show that the model works. Slide 13 is our agreement with Wheat State Healthcare. Last year, we entered an agreement and have direction from the legislature to work with mental health centers to help fund when they're doing an evaluation or restoration work in jails. We've got that up and running. 23 mental health centers have staff that have been trained to conduct competency evaluation, and 18 have trained staff in doing the competency restoration. We keep doing that training. We try to keep it up to date. The chart that's there on slide 13 shows the number of evaluations that mental health centers have completed by month over the last calendar year. And it tails off at the end of the year. That's not really a function of what the mental health centers are doing, but just what's available to work on. But again, that's worked well. We are finding additional mental health centers working in partnership with jails and in counties where the courts are amenable to getting restorations done in the jail setting. And then I think the last thing for me is reimbursement to counties. Couple of slides on 14 and 15. Last year you added some language in Senate Bill 228 that authorized KDADS to pay law enforcement for time that some criminal defendants waiting in jail for a placement at Larned for competency evaluation or restoration. And then also authorized us to pay hospitals and law enforcement for time when someone is waiting from the point of being screened for a state hospital until they're admitted to a state hospital or state institution alternative. We set those programs up over the summer. We've been answering lots of questions, taking reimbursement requests from counties, law enforcement, hospitals, and then trying to write checks as quickly as we can. So on slide 16, just to show you what our progress looks like for Senate Bill 228, so those are the competency evaluation and restoration waiting times. We've paid out through essentially the last week in December, $6.2 million to counties. And that does go to law enforcement is typically who's submitting those requests, either the sheriff or the jail operation, and that money is going back to the counties. The chart on the right-hand side is the House Bill 2184 is for involuntary commitment, either going to hospitals or some law enforcement agencies that are waiting with folks who are waiting for an admission, primarily to Osawatomie, but could also be Larned. That we've spent a total of $185,000, almost $186,000. That's been a little harder to take up. We've had some interest. I think this represents about maybe 12 providers or so that we've been paying. We've gotten some outreach over the last couple of weeks, actually, from some larger hospital systems that are interested. The biggest obstacle is not so much with the hospitals, but we've got to get them set up in the state accounting system, and that takes a little while. So I think that may have discouraged some folks from submitting requests, but we are working through that. I think when you look at this again next quarter, if the couple of large hospital systems that we've been talking to and working with, we can get them some reimbursement claims, this number is going to be pretty significantly different. But the program's working, and we've heard good feedback. We try to keep, if we run into a problem, we try to figure out if there's something system-wise we need to do on our side. But I think it's been a good cooperation, and we think it's working fairly well. That's the last part I have about state hospitals. Happy to stand for questions, and then we can turn over to Drew.
All right, thank you, Scott. Representative Carpenter.
Thank you, Madam Chair. Scott, thanks for being here. Kind of saw you enough this week. You're probably tired of me by now. On OSH, so when are we going to be able to get Medicaid certified? I mean, we are on part of it.
On part, yes.
But when are we going to get fully certified?
So we will certify the Bethell building once it's complete. We can't request it until the building's done. So that'll be March or April that we'll go through that certification process for Bethell. On the other side of the hospital, on the Osawatomie, where we're serving people who are either on competency cases and we're doing their restoration or evaluation, or we're holding people who are on a care and treatment order but they have longer stays, that part of the hospital is not certified because it's not a certifiable service. So CMS won't compensate us for that anyway. So I think when we certify Bethell and have our acute unit, and that's reimbursable by CMS, the other work we do at Osawatomie is not compensable. So I don't think it makes sense for us to try to go through the exercise of bringing that up to a certified standard and do that. The state license works for the model that we have. Honestly, as we work through the Witchita building planning, thinking about where the spaces are, what we need for the whole continuum of care, one of the things we find is that we've got some patients that need, I mean, they can get that acute stabilization, but they need some longer term support before they're ready to go back to a community and work on inpatient or on outpatient settings and get services from the mental health centers. So we need some beds that are a little longer term, and pursuing the Medicaid reimbursement for that's probably not the quickest thing to do in the meantime. So it's a great conversation. I think our goal is to get the Bethell building certified so we can maintain that with a few more beds. That'll help us on the revenue side. But I think we're comfortable where we are with the rest of the campus and the services that we're providing, and whether Medicaid's available or not for those services.
So, and also, so thank you for that. Adair's already certified.
Yes.
So Bethell, when it's done, will apply.
Yes.
So, Scott, I want to take a minute to thank you for all the work you've done on these mobile competency evaluation deals and the work with Wheatland and all that kind of stuff. I think it's taken a huge load off out there, as you can see by the numbers. They're not as high as I'd like them to be, but they're getting there. And then
I appreciate the partnership with the mental health centers and Weed State. They've been great to work with, and clearly they see the need as well. So we'll keep working on that relationship and keep moving forward.
Very good. And then finally, on Senate Bill 228 and 2284, House Bill, so are those in the budget this year? Are they a budgeted item, or does this?
So Senate Bill 228 is self-funding. The statute actually authorizes the program and creates the mechanism for us to get access to the general fund directly. So you don't need to do anything with that as long as that stays in statute. The House Bill 2184, that is a budget proviso. So to continue that into 2025, we need the proviso continued or extended into the next fiscal year.
And that wasn't in the governor's budget?
Representative, I don't remember if we wrote that into the appropriations bill language in the governor's submitted bill. I'll have to check. The funding is there. You appropriated money last year. We're not going to use all of it that you appropriated. I'd be very skeptical to think we're going to spend all of it. So and it'll reappropriate. So we don't need more money. I think we just need the authority to continue. And I'll check and see if that's in the bill or not.
I didn't see it in the budget, but maybe I've missed it. Thank you. Thank you, Madam Chair.
Representative Reese.
Thank you, Madam Chair. I had mentioned to you about a situation out in Reno County, and it is the individual that you had already confirmed. So I know there is a young man in Reno, currently in the Reno County Jail. He's been there, sounds like going on 2 years, if not longer. Is it? Yeah. So, and I know his family's sending us emails. And so one of the things that I'm confused about is he is there because he needs a pre-sentence evaluation versus a competency evaluation, is my understanding. Is that
That's
your
right.
understanding
Yes.
of it? So the mobile competency can't do that evaluation?
No, we've looked at that particular case, and I can speak about it in generality. So, but to do a pre-sentence evaluation, and I'm not the expert, but I may not get every T crossed, but to the pre-sentence evaluation, the way we approach it now, the court order for a pre-sentence evaluation orders somebody to be committed to Larned. So the court order itself directs an admission to Larned State Hospital or the state security program. So that's obstacle number one. Obstacle number two, to doing it mobily. Obstacle number two is that pre-sentence evaluation is a lot of observation of the defendant, testing some of the other things that we do on the campus, not just because it's on the campus, but because that's where our clinicians are that can do that. So there are some of those testing elements and observation elements that go into the report that's submitted to the court pre-sentence that you have to be, the individual has to be with us to be able to do that observation and evaluation. So that's the second obstacle to doing it mobily. We have looked at it several times for that individual if we could do it mobily anyway or try it anyway, and we just can't figure out a path to get it done. Even if we could get the court order written differently, I still think we'd have a problem doing all the things we need to do to complete the report back to the court. But it is one that we watch, we evaluate, that list of people, even though it's long and the days rack up, it's actively managed as much as we can actively manage when we've got limited number of beds to move people through. We talked about, could Osawatomie do it? I mean, I feel like we've exhausted what we're able to do with the limits on our resources and where our authority lies.
Follow-up question. Thank you, Madam Chair. I have a follow-up then. And what I don't know is if this individual is receiving mental health services in the jail, or is it that he can't receive like medication or therapy or anything like that because of that observation piece of it?
He could, if the jail, I believe that the jail is offering mental health services. I've spoken to the mental health center that's in that area that provides, I don't know that's all the mental health services, but a good chunk of the mental health services in the jail. Spoken to them about the case. I'm a little less informed about what's actually happening inside the jail, but we've reached out to the folks that we would reach out to see what else we could do to help him while he's still in jail.
One last question, please. One last question, Scott. Does the county jail, are they eligible to receive that wait time payment? Is that cover this individual also, or only a different category? Or only those that are waiting to go into like a state hospital, maybe?
I don't know that we've ever gotten a request for somebody who's on a pre-sentence evaluation, but I don't know that I have a problem with it. I'm probably the only person who has to decide. So the one thing that we could, sorry, thinking through it actively, we don't have to wait until he's actually admitted to Larned. We can pay in the meantime as long as we've got an order and there's time waiting. I haven't explored that with the jail, so I'm happy to talk to him about it, and I'll reread the statute. The statute does talk about ordered to Larned for evaluation or restoration. I'll see how creatively I can read that to include pre-sentence.
Thank you. Thank you, Madam Chair.
Well, and Scott, and we've got individuals sitting in other jails that have been there for a long time
Yes.
waiting on. So how would this individual be different than what we're facing in our other jails?
Other than that he's got a pre-sentence evaluation, which is a little bit unique or a little different. Most of the people on the wait list are waiting for restoration, I guess what we call standard restoration treatment. But that's part of the reason why we haven't, although we've been requested to move him up on the wait list or advance him on the wait list. I'm not comfortable doing that, given exactly what you said, that there are lots of other people who are waiting for, and I don't have a reason to, I mean, I'm struggling to come up with a reason why we advance one person over another. We do look at the list, and if there's something that happens in the jail that we need to assess, we will. But outside that clinical presentation, I'm uncomfortable just picking somebody off the wait list and moving them up. But it is a good suggestion about the payment side of it, that they are holding the person waiting for us to have a spot for him for pre-sentence evaluation. So that, again, I'd like to read it more closely, but I think that fits at least the intent of Senate Bill 228.
Well, because if I recall correctly, and I may or may not, but I think like in Sedgwick County, you've got some over 300 days and maybe over 400 days? Or was it close to 400?
I don't know what the last number was, but Sheriff Easter's had examples of individuals over 400 days.
Right. All right. Okay, I'm going to let Representative Ballard jump ahead because hers is on this topic.
Yes, what we're talking about. You know, the reason why I guess you're asking so many questions about that is because we've all received these letters.
Sure.
About the 600 and some. Now, I don't know who wrote it, but it's a pre-sentence. I can't understand why a person, I don't care who it is in jail over 600. I mean, has there been a review of this? Because we haven't been able to move forward. I guess I have to ask, it must be legal or it wouldn't just happen. But what would be the difference if this was my son and his dad and I could pay for a top-notch attorney to come in and look at this situation and of course, review other people that have been there a long time and remove me from this and put me someplace else because it's a pre-sentence. So I can't understand why you would just be there that long. And that was one of the reasons that we did that proviso in order to open the services up at Osawatomie. Yes, it was always court appointed and everything else for voluntary. But when we looked at that, the jails did not want to serve as a facility for mental health services. But in this case, it seems that if you've been there that long, you have been that facility. And I'm just wondering, if someone had that kind of money and all that prestige, would this move it, or because this person has no means, I'm assuming, we go through the procedure?
Representative, from our perspective, the State Security Hospital in Larned, the court order says he's got to be committed to Larned State Hospital. So that's what we're working on doing to get him to Larned to do the evaluation. We've been ordered to produce the evaluation. I can't really speak to what's happening inside the jail or the court process. I've asked similar questions when I've spoken with the family and tried to get information. I don't have a lot more to say about that. I don't, in terms of the status of his criminal case, we've checked on that as well to see if there's something else that can happen. Again, from our position as being ordered to do something, to figure out some other path to pursue. I don't believe he can get a private psychiatrist or someone else to do the pre-sentence evaluation because we're the ones being ordered to do it unless the judge changed the order. But I'm not aware of anybody else doing those privately as a pre-sentence evaluation. But I don't know that. That's been a little outside of our scope in terms of what we're being ordered to do.
I think Representative Ballard, because this is on a specific case, and if you guys want to visit with Scott after that, that would probably be more appropriate so we can move on with our agenda, if that's all right.
That's fine. I've said what I needed to say.
Okay. Representative Concanon and then Representative Petty.
Thank you, Madam Chair, and thanks for being here, Scott. I have two questions on the OSH beds, the number of beds available. It sounds like we have, I mean, with the moratorium lifted on voluntary admissions. But last week in Judiciary, the law enforcement gave us an update, and coming from Sedgwick County, they said that they were still housing a lot of people waiting. How does that match up? Is there still a wait list?
We're running a wait list at Osawatomie for available beds that's around 40, 45 hours. I think in our budget testimony, that's where if we averaged out last year, it's about 45 hours from when you're screened in and have the court order 45 hours to get into into Osawatomie when there's an available bed.
Okay.
So for a care and treatment case or somebody who's involuntarily committed, there is still a little bit a wait time of around 45 or 50 hours.
And I don't know that I know whether that was for care and treatment or for competency evaluations.
For competency, I'd have no argument at all. We've got a wait list. One of the things we have tried, in addition to mobile, is to manage the wait list between the two campuses, Larned and Osawatomie. So if Osawatomie is able to take somebody who's on the wait list and can provide the service that they need, Osawatomie is not as secure. There's no security behavior unit, so there are some limitations there. But if we can pull somebody off the list and send them to OSH, we do. But it depends on how the order's written as well. But so yeah, we are actively managing it. But if it's a competency case, I haven't looked at Sedgwick County recently, but I'm sure they've got 25 or 30 defendants waiting to get into either Larned or Osawatomie for competency.
Okay. And second one. So switch to Larned. Your graph shows 55% vacancy rate positions. So are we still using agency?
Yes.
Do you know how much we're spending a month on agency?
I could do the math. We're estimated to spend a total of $40.3 million this year. That reflects about 200, somewhere between 200, 210 agency staff, nurses or direct care staff that we have on the campus every month.
Okay.
So when you look at our vacancy rate, we've got filled nursing positions of 150 or so. The other 200 people that we need to keep the place open at the capacity it is are our agency staff.
Okay, all right, thank you. Thank you, Madam Chair.
Senator Petty.
Thank you. And mine goes back to the Bethell remodeling. I remember the other day in a subcommittee hearing when you talked about you can remind me if I'm correct or not, but that those patients that are there, there's no outside time. So at the Bethell courtyard, which is in the request to be remodeled. So could you share with the committee what that would provide for those clients and things?
Sure. Thank you for the question. So Bethell, we invested all of the budget inside the walls, which is exactly the right thing to do. But because that's a secure acute unit, we don't move those patients to any of the other facilities at OSH for recreation. So they can't go to the gym. If our pool's open, they couldn't do that. So what we've been trying to figure out is how do we provide a therapeutic space that's also that's outside for those resident or patients to use. They can use the courtyard that's there. The Bethell building, we should have brought the map and the photo. Sorry, I didn't think about that. But it's there's an enclosed courtyard. It's a three-sided building, so there's a triangle in the center of the space that is a courtyard. It works now. I mean, it's a grassy area. There's picnic tables, but there's grass where grass will grow, and there's picnic tables. So what the team would like to do is add some other landscaping, work on the drainage so it doesn't become a muddy mess in bad weather, wet weather, some areas where people can play games, do gardening, things like that. So in the governor's, in our budget request, we did ask for an enhancement to fund the drainage requirements and then do some other things about just providing things in that space so that it's a therapeutic outside space. It's about $469,000, I think, if I remember right. It's in the governor's budget to use state building fund dollars to do that project in 2025.
Thank you for that update, because it does seem to be an important piece to provide for the quality of care that's going on there. Thanks.
Thank you.
All right, committee, are there any further questions? All right, seeing none, thank you very much, Scott.
You're welcome.
Committee,
Drew
we're
Adkins.
going to,
I'm sorry. I was going to invite Drew Adkins up, but it's your committee, so I'm sorry about that.
We've worked together way too long, Scott. That's our problem here. Committee, we are going to go ahead and break for lunch because our lunch is outside here, and I had informed Drew that he would come right after lunch. So we will try to get started here in about 25 minutes. All right, we're going to go ahead and get started here. Feel free to continue with your lunch, folks. And Drew, welcome to committee. And congratulations on your new position.
Thank you very much, Madam Chair.
You're going to be a lot more fun to work with than Andy, I'm just saying.
You know, those are your words, not mine, but yes, I agree. Duly noted.
You can tell Andy I said it.
I will. Members of the committee, there are some slides for our certified community behavioral health clinics that I'll go over. I believe that you have the full slide deck in front of you, so if you have questions on that, let me know. And I'll give it just a moment to let the slides catch up here. We're going to start with just some CC. That threshold. So we have two more that we're working with continuously to get to full or to certification by July 1, 2024, and that's our timeline as laid out in the statute and legislation. We have our federal demonstration program, and we have an application for that. Just a quick refresher, this is an opportunity that the state of Kansas, KDADS, and behavioral health are going to be applying for that would give us access to enhanced federal medical assistance percentage, or FMAP, and also some enhanced technical assistance around our programming. So we're excited to apply for that. We apply, I believe it's March 30th of 2024, so just here in about a month or two. And we have an anticipated start date, should we receive the award, of January 1st, 2025 for that. And I will move on to our successes here. Again, I talked about this a little bit before, but our 9 original locations, we have gotten to full fidelity, and I do want to take a moment to say that this means that they have had to hit a score of 80% or higher to implement the model, which is truly incredible, especially in the time frame that we were given to be able to bring them on. And so I'm very proud of our team at KDADS. I'm very proud of the network of Association of Community Mental Health Centers to get to this point, and we're excited to get the rest of the community mental health centers on board as well. We continue to work with the Association of Community Mental Health Centers, as well as the final 2 centers that we are about to bring on board. I believe that is Iroquois Mental Health Center in Greensburg, and then also South Central Kansas in El Dorado, I believe, are our final 2 to come to certification. And we do believe, again, that they're going to hit that a little bit ahead of schedule, but certainly by the July 1 timeframe. Right now, internally, just kind of our success that we wanted to share is we're working to develop a further review process of some of the other programming that we have in behavioral health to account for some of the other evidence-based practices that we have. And so we're trying to encumber that to show a more representative viewpoint and perspective of the continuum of mental health and some of the ways that we can gauge how successful our certified community behavioral health clinics are. And I believe we do have a map. I usually bring this up in any committee that we're presenting on, and I'm not sure, we might not have that here, but we do have a map in the full slides if you're interested. There we go, thank you. Again, full disclosure, I am color deficient, and so I may not get this 100% correct, but the light, let's see here, the light, or the white, the non-colored counties there, those are the 2 that I mentioned before that are not certified quite yet. I believe the light blue are the ones that are fully certified and through our process. And then our darker blue, those are the ones that are in between being provisionally certified and then fully certified. And I think with that, that is all I have for the slides, but I'm happy to stand for questions should any of the committee have any.
Committee, questions for Drew? Give me just a minute. I'm getting ready to go back here because I had Would you mind getting us a list of the CCBHCs and then show us, what their status is?
Absolutely, yes.
And then the other thing is, because I know the other day we were looking at the original fiscal note back in 21, I believe it was, that was for around $75 million, somewhere in that ballpark. So an idea of what that fiscal looks like today.
Okay, for the full implementation,
Yes, for
is
the
that
full
correct?
implementation.
Absolutely, yes,
That
we
would
can
be
do
good.
that. Yep.
Okay. Committee, are there further questions for Drew on this? No, it's only for my benefit, Representative Concanon. No, he'll send it to Dave and Hunter.
Good morning, committee. I thought I was going to be the easiest one, but Drew actually did have less slides than me, so I will roll through mine. I believe I start on page or slide 26, even with the hit out ones. I think it's still 26. So one of the things that my commission is tasked with doing is providing the state license for psychiatric residential treatment facilities, or the Psych Under 21 exclusion. We do that on an annual basis, so at least once a year we're in there. It's an announced survey, so that is much different than my other realm of nursing facilities. We do announce when we're coming out on these, but we do an annual survey where it is announced to ensure relicensure standards are met. And then we also do unannounced inspections when we have a complaint or a error come in. Then to kind of give you an idea of what that looks like, we have 10 PRTFs in Kansas. For the 2023 year, we did 24 inspections. Of those 24, 7 were unannounced, but we're actually in those facilities, even on an announced basis, more like every 6 months. We are getting to a point where we're going in about twice annually, not for a complaint, not for a concern, but working with the provider, making sure that there's no questions or concerns, and making sure that their training and their onboarding and everything is continuing as they continue to find more people to work there. Next slide. The rest of my slides are pictures or graphs, however you want to call it. So the first one here is something I report on, and I have been for quite some time now. It is, oh, they did not. This was, okay, well, never mind. We'll go with this. Also something I regularly report on. This is the number of courses for CNA, CMA, and HHA that are approved. It gives you both the fourth quarter and then the year-to-date information over several years. And then the next slide I'm going to guess is, yep, the initial number of certifications for those same, types of work categories. So once you've passed a course as an individual, you come to KDADS, you get certified. This number represents the number of people that came to us and said, I want to get certified since I've passed my class. Okay, next slide. So this one I had started on not too long ago, but I continue to update. It is solely for adult care homes, but this is the number of change of ownerships, number of closes, and number of opened, and this is by facility. Next slide. This one depicts the same information, but by bed and not by facility, so you can see the number of available beds that have been closed down over the past 5 years. And then the following slide is a graph of the same information, but opened beds for the past 5 years.
When the print gets small, I have to kind of focus a little bit. Committee, are there questions? When I'm trying to look at this chart, if you'll flip back. Yeah. No, that's not the right one. Yes, that one right there. Does any of this take into account the number of beds that have been pulled offline because of staffing issues?
No. In particularly in the nursing facility realm, so when you're looking at on those that far side over there, the certified, duly certified, that when you go to change beds in that capacity, you're changing the certified bed count, and CMS puts some rules around that, which says that you can only increase or decrease twice a year. So you can do one request for an increase, one request for a decrease. You cannot do 2 requests for a decrease within the calendar year. The other thing is that you have to provide a 45-day notice prior to the date you want your change to be made, and your change can only be made at the facility's cost reporting year or cost reporting quarter. Typically, we see facilities lower their number of certified beds or their bed count. We get notification May 15th. That is 45 days from July 1st. July 1st is the day that they're assessed for the amount of bed tax they will pay for the following year. So typically, we see bed decreases that coincide with that quality care assessment that happens on July 1st, so that they're not paying above or below what they're wanting for that next year.
All right, thank you. Committee, any further questions? Representative Carpenter.
So that's only with licensed beds, so there may be someone that has a license out there that has closed, but their license has expired, is that?
No. So we have had a few facilities that, as we've went out to survey, we have found that they have 0 residents. We did have one case in particular where we found that the place had been completely abandoned. We had been trying for months to contact that place and work with them. And we have taken the actions necessary to ensure that that facility and that facility owner cannot open again. But typically, this is hard because we're just out of COVID. Typically, every year, every facility that has a license as an adult care home with our commission has to provide an annual renewal application. It's an online process, but part of that process includes their beds. So if they're going to, they have to tell us what they have on their license, and it has to match what we have in our database. But we don't have a good sense of how many vacant beds there are because of staff or licensure. So many places, you know, if you're licensed for 45 beds, I can tell you that they can have up to 45 people. I can't tell you how many people they actually have. I mean, we do on survey. I can go back through on any survey. The first thing of our survey when you read a 2567 is the number of residents in the census for that building. But that's how we would capture that information.
Very good, thank you.
Senator Fagg.
Thank you, Mr. Chairman. Thank you for your presentation. On slide 29, and you might have went through this, and I was flipping through this, but when I look at closed versus opened, it looks like the net numbers are +5. So that's kind of a positive thing if I'm reading that right.
It can be open to interpretation, but the reason I provide the slides that go past that into the bed types is because what you'll notice is while the open and closed for facility and adult care home does kind of have that positive net, what we actually see is the number of nursing facility beds closing and home plus facility beds opening. So that's net-wise, yes, but the level of care, no.
Okay, thank you.
Representative Carpenter.
And so to piggyback on that, why is that? You know the answer. You're just figuring out how to say it.
Staffing is the word. Lack of staffing, lack of available staffing, lack of trained staff. I think some of the other things that we've seen, the most recent one that is not actually accounted for on this list because they have not fully went through the closure, but they are at a point where all of their residents have been notified, so I do feel comfortable telling you. We did have a facility that closed. They actually had to remove all of their residents mid-December because they had some HVAC issues during some of the peak parts of winter, and they were not able to hold temp in their building. So we have received notice since then that they are going to close the building entirely. But it is not due to staffing this time. It is due to the aging of the building and the inability to come up and cover the costs of a county-owned building and the repairs needed to bring it back up to code.
And I was going to say regulation too. There's a lot of different regulations, as you well know, between a nursing facility.
Absolutely, yes. So the regulation side that he's speaking to, yes, there is quite a bit more extensive detail on the regulations required of a nursing facility. In particular, most of that extensive stuff comes from the federal government because they must also answer to the federal government, as opposed to a Home Plus that does not have that same response. They only have us.
You're welcome. It seems like I heard something the other day about we may have some inspectors that are going into some of these facilities with body cams. Do you know anything about that?
I do. It is not KDADS inspectors. It is inspectors of the Office of the State Fire Marshal. We have not had a chance to meet with the new fire marshal, but it is my understanding through some email communications that the interpretation of it is that the State Fire Marshal Office is considered a law enforcement agency, and they have provided education as to why and how they're going to be utilizing those cameras. I just received actually this morning when I was sitting here an email from Brenda McNorton that they plan to send out to providers about the use of the body cameras and how they plan to protect PHI and HIPAA.
I'm just not happy about that at all. And I think some of my members probably share that attitude as well. There may be a bill in the works if it hasn't already been introduced, because those are people's homes. You don't go walking into their rooms with body cams. I'm sorry. Unless and law enforcement works under a different level. So if they think that they're a unit of law enforcement, then we need to be having that conversation as well.
Thank you.
And I know that's not your deal. I just want to have that out there that, maybe we'll get their attention. Maybe they'll take and listen to us. But if they choose to continue to be arrogant, then we may have to have deeper, further conversations with them on that. Okay. And I might, note, committee, is that, you've heard us talk about the number of beds that we have offline because of staffing. The shocker that a lot of people aren't paying attention to is we have hospital beds offline right now because of staffing. So we are hitting critical mass on the staffing issue in Kansas. Representative Carpenter.
Just one other thing, Lacey, could you address the issue we're having with Goodwill?
Yes.
The bill is being written as we speak to address that issue. So anyway.
Yes, I've been meeting with Chris Stanley. He is a representative of Goodwill of Kansas. We've been working with Mr. Stanley because the way our statute is written, it requires that if you are a provider of services, in this case IDD day services, any employee must pass a criminal record check and background check. And then within that statute, it is a very specific statute, and it goes into detail what those convictions can and can't be, how long after the conviction before a person can be employed. The problem that we were having and we were working through with Mr. Stanier is on his license application to KDADS, the entity that is on the license is Goodwill of Kansas. So every single employee of Goodwill of Kansas is now subject to that background check statute because that is who the license is to. I have been working with Mr. Stanier because they do have a separate LLC that I understand currently that they never utilized. They created a LLC for a different reason, something to do with taxes or something, I believe. To no end, I'm working with Mr. Stanier to come up with a way to provide a change of ownership so that his license will be to the LLC and not to the entirety of Goodwill of Kansas. And then only those employees who are working with the IDD members would be an employee of the LLC and subject to the background check, and not all of Goodwill of Kansas. And the reason why this is important, and it's a hard one for us to kind of go down, is because not only does the Goodwill of Kansas provide employment and education for those with developmental disabilities, but they also provide those kind of training and work opportunities for inmates being released out of the Department of Corrections as a second chance opportunity. So we're trying to work how we can figure out so that Goodwill of Kansas can still provide training and work opportunity to both of those populations of Kansas citizens.
Thank you for that. I just thought the committee ought to know of the issue and how that's working. But we are getting a bill written right now for introduction to correct the problem. Thank you for that.
Just amazing, all the work that we try to do to take care of our most vulnerable, and the regulations and rules and interpretations are getting in our way, and it's getting in the way of the care of our individuals. All right, committee, are there any further questions for Lacey? All right, seeing none, thank you very much, Lacey. Next, I have Seth, is it Kilber? I didn't butcher your name for a chance. Assistant Commissioner, Long-Term Services and Supports for KDADS. Welcome to committee.
Good afternoon, committee. This is actually my first time, but I have been a long-time listener.
Welcome. They didn't tell you we bite or anything, did they?
I won't say what was said behind closed doors. So, kicking off, I think, with our home and community-based services, we're looking first at just overall enrollment as of data from 2023. So we've got this broken down by waiver, so you can see by each individual waiver how many individuals are currently receiving services, and if the waiver has a either proposed recipient list or a actual wait list, you can see the numbers there. We don't have a total down there, but I've done the mental math for you. We've got about 27,000 Kansans receiving HCBS right now. Next up is just a brief update on our 10% FMAP enhancement projects. So over on the left-hand column, we've got the projects that are currently in development.
Okay, we're going to have you hold here just one moment because our slide started with aging and nutrition services. Yeah, because the HCBS is down on page 40-something. All right, I'm going to look at Representative Ballard's. I'll figure it out. Okay, so you may have to bear with us if we have to bounce back. So, all right, go ahead.
Okay. So,
the HCBS.
okay, all right, there we go. I think we got it straightened out. So I am on page or slide 48 currently. So these are 10% FMAP enhancement projects. You can see on the left-hand column there. These are the projects that are currently in development. We're working on developing the RFPs to get these out right now as we speak. So in the middle column, we have those projects that are currently underway and we already have a vendor or contractor on board and is doing the work. And then over in the right-hand column, we've got those projects that have been, completed. And so we plan to update this in future testimony as well. Next slide on number 49 is an update on our waiting list study completed by KDHE. Really, there's two overarching aims to this study. The first aim is to first collect existing data and analyze what we have on those individuals on the wait list. That has kind of two additional components to it. To understand the overall makeup of those individuals who are on the IDD and PD waiting lists, but also to help create a predictive model so that the department can understand the service needs and potential crisis exceptions, which will inform kind of our aim number 2. So next slide to 50, which encompasses the survey data, which has begun and is underway and will continue probably through May, but that's a little bit dependent on just the response rate. So we'll be monitoring that with KU here. The aim of this second aim through these survey data collections is really to understand the demographics, really get into the nitty-gritty of what kind of services people want and how that kind of dovetails into how we can forecast for the needs that people have been, for those who have been waiting quite a while. All right, on slide 51, there was a request for an estimate on standardizing PCS rates to match the IDD waiver. I think we've actually, this one was really just for PCS rates, but we've also got another estimate that didn't make it into the slide for additional services outside of PCS, but my understanding is PCS is kind of the pain point as far as standardization goes. So just the bottom total there, sorry, Lee, go back one. Just the bottom total there, if we were to focus just on PCS, it'd be 16.4 million all funds. However, we did look at folding in those additional IDD services to standardize, and that number I think we were at, it's not on the slide here, but 26 million all funds when we look at additional services outside of just PCS. And then on the next slide, you'll see the table that just kind of breaks down the discrepancy between the rates on the different waivers. All right, on slide 53, there is about target case management for services for individuals on the frail elderly and PD and brain injury waivers. Right now, with this next iteration of KanCare, we do have in there a request for the MCOs to propose like a community care coordination model, which would serve a similar function that TCM currently serves on the IDD waiver. However, we did go ahead and run the numbers to cover these additional populations under the TCM state plan benefit, and that comes to 8.3 million all funds. Slide 50, community support waiver update. That is where we're at. I know there's been a lot of interest in this one. The state has just put out a task order to bring on a vendor to assist us in writing this new community support waiver. So that is out right now with vendors being given the opportunity to review what we're asking and respond to questions. We're hoping to have somebody in place in March, would be our goal, April at the latest. So the new waiver will hopefully address some of the waiting list issue. We don't anticipate that it'll solve all of the wait list issue, but we want to get the start on that as best we can. It's really focused on offering less costly services with a proposed $20,000 annual cap per participant. Services right now we'll look at including transportation, employment, personal care services, a lot of those services that are often heavily self-directed, so giving the participant the power to direct their own care. However, as you've heard in previous testimony already, Stan, you're all aware of the staffing shortages across just the various networks in the care system. We're looking at probably a phased rollout due to just the network adequacy concerns, with hoping for a minimum of 500 people early on, which would be funded by 60% federal and 40% state funds, with those costs just kind of varying from 72 million to 149 million. And once we've got this contractor on board, we're looking at doing a full-fledged sprint, get a waiver application to CMS as soon as we can, and they will be working with the various stakeholders to figure out how we can best design this to meet the needs, given the services that are wanted and the annual cap as well. We would be looking at having services ready to begin by, either late 2024 or early 2025. Or sorry, I hear Michelle over there. Approval in late 2024 with services beginning at some point in the later half of 2025. And that is it for my slide updates. I will stand for questions.
All right, Representative Carpenter.
Thank you, Madam Chair. And before you guys have a coronary over this 72 million to 149 million, that is, I'm not sure what that even involves as far as participants, but so now on our wait list now, there were 500 slots in there. It was 13 million off SGF and 30-some million. So, but this is a lot. So that must be the total cost of how many? I mean, we have no idea how many people are going to be on the community support waiver. And so backing that up, what about the wait list? I mean, where is that? It's been plenty of time for those guys to get that done, and we're waiting on that, quite frankly. So when can we expect the wait list to be done? Is there anybody here that can answer that?
Are you talking about referencing the waiting list survey?
Yes.
Yeah, the survey collection has just started to begin. We actually, I think it was last week, we had to complete a no-cost extension. So the actual end of the survey period, and we anticipate having a final report in December of 2020 or December of this year.
Really? And why is that? Why did you need an extension?
I would have to go back and get with KU and our waiting list coordinator to really understand, but my understanding is there was a bit of a snafu with trying to get the survey out to the 20% population. We've kind of worked through those wrinkles now, and so we're I think on the right track, but we can get you a
in 2 years' time, I could have driven to every one of those houses. The 5,300 houses, I could have driven to those houses and got that information. And here we are 2 years into it, and we still don't have a final product. And it cost us, what, $1.5 million on top of that? I mean, this is just outrageous, and we're waiting for it, and here we are. And we still don't have any answers after almost 2 years. So, thank you.
Senator Gossage.
Thank you, Madam Chair. When the presentation was made to our committee a week or so ago for the Senate Public Health and Welfare, the contractor was supposed to be coordinating the stakeholder meetings, correct? The question is, if we're sending out all these surveys, and these surveys have been sent out, what, quite a while ago? You're just waiting for them to come back? Is that right?
I'd have to check on that, when exactly they've gone out.
Okay. And I'm assuming in the survey that we're asking the questions that we might have in a stakeholder meeting, like what's of these services, which of these services do you feel like your child or you would need, right? That's the whole purpose of this, for the community support waiver. And it seems in my committee, on the Senate side, that we are dragging our feet as to how long is it going to take this whole process to get the stakeholder feedback, when it seems like we should have already had it. And I'm not denigrating you or anybody else in the department that we don't have this yet, but it is very frustrating when we get all these emails from people like, when is this community support waiver? What is taking so long? We're happy to answer whatever questions you need. Just ask us. And it would be exciting to have so many of these people be able to come off because they don't need as many of the services. So if we've got the RFP out, when do we expect that to come back? And now, is that individual going to be coordinating the whole waiver process or just the stakeholder process?
It won't be an individual. I imagine it'll be a team of
firm?
folks.
Okay.
Yes. No, it's not just the stakeholder process. They'll be taking data from the waitlist study that we're currently doing. That'll be absolutely informing their process. They're taking this from cradle to grave for us.
And I also just want to say, I know at the last Bob Bethell meeting last year, we talked, and then the IDD meeting, we talked about what Missouri did and how Missouri got theirs, and I appreciate that the department reached out to Missouri to get some feedback on how they were able to set theirs up. How much of that is useful?
That was incredibly helpful. We did talk with them. As I recall in the conversation, we'd asked, we want to get this done as fast as possible. Do you have any advice for us? And they said, well, our advice would be just take your current waiver and just, reduce the services down. So that kind of was at odds with the services that IDD modernization committee had wanted. A vastly different service array is likely going to be offered on this community support waiver. So that was one point of just interest. But we're hoping and what our intent is that whoever we bring in is going to have extensive experience doing this in other states and experience with CMS, because we want to get this done as quickly as possible and want to get it done right as well.
Thank you, Madam Chair.
Senator Petty.
Well, this is a follow-up, I thought, where Representative Carpenter was going, but on that estimate that you provided there about the rollout plan and the 500 participants, and then you gave us a 60-40 breakdown for both federal and state funds. So that total there cost ranging from 72 to 149 million. Is that for that population, or if we're talking about if they're a total rollout?
I am not sure I quite understand your question, Senator.
Sorry, it's on page 50. It's on slide 55.
Is it for 5,000 or 500, this cost, right?
Is that cost there, about the total cost ranging from 72 million to 149 million, is that for 500 participants, or is that for the 5,000 on the waiting list?
Do you remember how we did that?
It was based on services, a low end and a high end.
Yeah, I mean, it was based on, I know it was based on kind of how we estimated the utilization. Like if we've got, a low end here, that would be obviously the lower end of the expenditures. But we don't really know until we can start actually developing the waiver and we can see how many people we could actually serve and what the network can absorb.
Okay, so this is an estimate for what could be the total cost for the somewhat unknown number. I guess it would be somewhere between that starting participant number and what's presently on the waiting list. Would that be correct?
Yeah, it's been a minute since we put these estimates together.
Okay.
So I'm going to go back and I'm going to look at that and get you some clarity on that.
I mean, my curiosity is, of course, it's important information, but it really impacts what we're talking about, the state portion of that amount. Thanks.
Yes.
Representative Carpenter.
So let me just kind of clarify some of this. So unknowingly, we don't know, but I believe that we can take half the people off the wait list, 2,500 people. That's $50 million all funds. So, but we don't know that figure because we don't have the wait list study back yet after 2 years' time and $1 million. But that's what it would be, is $50 million all funds, so it would be our portion 60-40. So it's not nearly as expensive as, and we capped it at 20,000, which the new cost is 53,000 for our a full-blown waiver. So anyway, enough of that.
Committee, further questions? All right, seeing none, thank you very much for being here. And you survived us. Representative Carpenter.
And Madam Chair, I did ask for the KU folks to be here for this, and I don't know what happened in that. Were they notified or whatever? But when they reached out to me for topics, I did ask for the KU folks to be here to explain some of the stuff. Is there no one in the audience? Very good. Thank you.
Step up.
Are you part of the study?
Okay, just give us your name so that everybody knows on the records.
I'm with the KU Center on Developmental Disabilities. And I just recently joined the study as support. And so I don't know if I can answer all of your questions. Evan Dean is the principal investigator, so if you have any questions. This is your answers that you would need, so.
Representative Carpenter.
I just have one question. When are we going to get the end of the waitlist study? When is it going to be done?
Well, the contract was extended because there had been, as Seth mentioned, several hiccups along the way. One of the things I want to assure the committee is that this is going to be a very thorough study. There were a lot of protocols that were undertaken not only to ensure the fidelity of the study, but to also ensure the safety and protection of the information of the survey participants. And so in order to make sure all those protections were in place, it took some time. And then also we spoke of a hiccup. When we had originally applied for the study, for the grant, we had anticipated that we could distribute the survey via email, but one of the things we found out is that there was only 2.7% of the people on the waiting list who had emails listed. And I think that was because we didn't really understand, and it's not just us, but the lack of data available on how we could reach out to these people. We found a solution to this problem, and as Seth mentioned, the survey is being distributed now.
It is?
Yes.
Well, 67% of these folks on the ID and DD wait list are on Medicaid, so that would have been kind of an easy stretch over to KDHE to find out through the application process where they lived and how to contact them.
Yeah, well, we thought we could contact them through emails, like we said, but we found another way utilizing the survey mechanism that we're using, which is Qualtrics. And so we are partnering with both the CILs, the Centers for Independent Living, and the CDDOs to make contact with these people so that they can get the surveys in their hands and we can get results here soon.
And on top of that, most of the CDOs also know the folks in their communities also.
Yeah, and so they'll be a really valuable a partner in this, so.
So do you have any idea when we're going to have this wait list back?
Well, like I said, we got the initial round of surveys out now. And what is happening is we're doing in tranches of 20% of the waiting list at a time until 20% of the waiting list responds. And then once we get that, we can do the analysis of the data and present the reports then.
So that would be 1,000 people at a time, roughly.
Well, between the IDD and the PD waiting list, I believe we're looking at roughly 1,800 people at a time, if I remember correctly, between 1,500 and 1,800.
I forgot the PD was in there.
Yeah.
All right. Okay, very good. Thank you, Madam Chair.
All right. Senator Fagg.
Thank you, Mr. Chairman. This survey that you have, is it possible to get a copy of that? Is it a complicated survey and people don't fill it out, or?
Well, it's going to take a while. We anticipate that it'll take a half hour to fill it out. I have to check with Evan to make sure if we can get a copy to members of the committee, because I'm not exactly sure. I don't feel comfortable answering that question. One of the things that we did, and this is one of the things that took some time, is we wanted to make sure that the survey not only answered the questions that the committee wanted answered, but that it was phrased in a way that people with disabilities can understand them. And so we did a lot of testing with the survey beforehand to make sure it was in plain language, so that we made sure that people answered it the way that they reflected the questions so that we get accurate data.
All right, let's make sure that we get a response back, whether that can be released to us or not. Okay. Sure. Further questions, committee? All right, seeing none. Thank you very much for stepping up. I appreciate that. Okay, who's next on our list? I'm not seeing the name. That was it for KDADS, right? Okay, now we're on to it. All right. All right. We have Nan Perrin, Senior Director of Behavioral Health and Life Share Sunflower Health. Welcome to committee, Nan. Did I butcher that name again?
No, you
Okay.
did wonderfully. So thank you, Madam Chairperson and the committee, for the opportunity to present. I am Nan Perrin, as you mentioned, Senior Director of our Behavioral Health and Life Share at Sunflower. I have the wonderful opportunity of starting off our Sunflower updates with a little information about some Centene Foundation grants. So that is a grant that we're doing in partnership with Centene, our corporate partner. And we are working with LAD, which is Living Alternatives for Individuals with Developmental Disabilities. They're an organization out of Cincinnati, Ohio. They've been around almost 50 years, and they had the same things that you guys are talking about. They had been providing services, high-quality services to individuals with developmental disabilities for many years, but they keep coming up against this caregiver crisis, right? And so they were looking for how could they more effectively and efficiently support members with developmental disabilities. So they did a study in partnership with Xavier University of smart living technology. So what is smart living? So smart living is really how can you leverage technology and training to make sure that the supports and services are available to the individuals when they need it, where they need it. And so with total respect to the individual's preferences, as well as working in collaboration with their guardians, doing assessments, really identifying what will help enhance the independence for that individual. They really train their staff. They create that infrastructure within the organization to better provide those supports. And really looking at how those supports are all within the natural community. So all across Cincinnati, Ohio, they are providing this support and service. So we are providing a $390,000 grant to them to bring the technical assistance to providers who have indicated interest in this. So for several years now, we've been working on this project, and in collaboration with InterHab, LAD came and presented to groups of developmental disability providers, and Johnson County Developmental Supports and Cottonwood are going to be the first two organizations that work with them. We actually had a launch on Wednesday, and so a kickoff of kind of that initial discussion for that. It's going to be a 2-year project, and again, this is when members, those individuals with IDD, select having technology to enable their independence. Next slide. So the LAD Smart Living model is completely person-centered. So each individual who does say, I'm interested in technology enabling my independence, is going to have an individualized assessment, really looking at what technology matches the needs that they have and how that can be leveraged to better provide that support to them. Those are all in person. It's team integrated, so the whole agency will work together with that member to identify what those supports are. And really, one of the great things about this is that we can learn from the expertise of that agency that's already done this. So they've worked, on this project, and so they're going to help JCDS in Cottonwood, and we'll be looking for 1 or 2 other providers in the state to come along after that. Next slide. One of the key things about LAD Smart Living is really about a new staffing model. So right now, when you look at many of the residential supports for individuals with developmental disabilities, very crucial direct care staff. It's very important, but oftentimes they spend a lot of the time they're there waiting for something to happen, waiting for a need to arise. So there's a lot of what you might call downtime. And when they look at this new staffing model with LAD, they really are identifying both a match of that direct care provider's expertise to the individual's, like what does the individual need to work on? Maybe it's meal planning. And so they have someone who is available to them for meal planning, and they really do that targeted. But other times of the day, they're not just waiting for that next meal to come, if that makes sense. And they were able to, in their study, move from 16 to 18 people supporting a living situation with potentially 3 to 4 individuals living in that house to 5 to 6. And so, that ability to reallocate those FTEs. They shared in all of the work that they've done, they did not eliminate positions. They just were able to create opportunities to support more people. As we've talked about, we know there's a waiting list. We also know that there's not always provider bandwidth to do that. So this opportunity will help build some of that capacity within these providers. And just wanted to put a little bit of a graph in there. I can't do a presentation and not share data. But again, they did a study with Xavier University, really looking at the independence change and the ability to work with individuals who their family and their supports rated their level of independence pretty low. They were utilizing direct caregiver support for all of their activities of daily living, all of their shopping, all of that. And yet, with 3 years of support, each individual moved to where they were doing more of those things for themselves and rated that they were both higher quality of life, but also a higher level of independence. And I think that's my last slide. It is. So I am happy to stand for questions at the appropriate time, or you can call Tiffany up.
All right, thank you. Next, I have Tiffany, and I always mess this up.
Yep, I'll take it. I am Tiffany Eulenhake, Senior
There we go.
Director of Quality at Sunflower Health Plan.
Welcome, Tiffany.
Thank you. Thank you, Madam Chair, Landwehr, and Committee for the opportunity for us to share some of our initiatives around cervical cancer screening and prevention. So we are right off the heels of January, which was Cervical Cancer Awareness Month. So we thought it'd be timely to bring some information about some of the initiatives that we have launched. Go to our next slide. So in a 2018 review of the data, we found that our Kansas Medicaid members were 12%, their screening rates were 12% lower than other insured Kansans. Looking at this, we launched a 5-year performance improvement project with the aim of increasing this screening rate to 59.5% or higher at the end of the 5-year project, and that would be a 5% improvement from baseline. So we used 2018 as our baseline year and launched initiatives using our PDCA model, which is Plan, Do, Check, Act. Through 2019, 2020, and 2021, we focused on these interventions. We were excited that we met our goal early. Then we added a 2% stretch goal on top of that. So these interventions were targeted at members, providers, and special populations. So our member initiatives were multimodal and included text outreach, mailings, warm calls, and automated phone calls to remind members to get this screening completed. Through the provider, we provided gap in care reports so they could reach out to their patients that were outstanding for these screenings. And then we educated on special populations. So we found there were a lot of myths that we needed to educate against and dispel with our IDD population. Our second initiative that I'd like to cover is around prevention. So one of the key areas that can help prevent cervical cancer is HPV vaccination. So HPV stands for human papillomavirus. This virus is responsible for over 91% of total cervical cancer cases. So it's critical that we get this immunizations to the eligible populations. So we looked at our data and found that our adolescent population that was eligible for this vaccine had a little bit lower compliancy rate versus some of our other immunizations. So this requires a two-part series. We found that there were even lower rates with getting that second dose. So we partnered with various health departments, Holy Family and Vibrant Health and KCK, and they administered the vaccines, and we did the outreach. So we provided a brand new pair of shoes to the member. When we did the outreach through the caregiver or through the parent, we were able to offer for the member to be able to select what brand, color, and then the size of shoes that they would prefer. So when they went in to receive that second dose of the vaccine, they were actually able to receive the shoes at that time. We've had great feedback from this, and our team that have been at these locations have had positive feedback from both the community partners and the members that we've been able to reach. And then we also included some additional information in your packet around submission moments and other information you can review at your leisure. So any questions?
Committee questions? Representative Reese.
We've been passing each other a lot in the, in the Capitol, so good to hear your presentation. On the Shoes for Shots program, do you know how many boys or girls participated?
Yeah, so we launched this last summer, and we've given over 80 shoes to date, and we will continue this through 2024.
Thank you.
Committee, further questions? All right, seeing none, thank you very much.
Thank you.
Next committee, we have Maria. Is it Wheeler or Weiler? Weiler. All right. Member Experience Coordinator, United Healthcare, Community Plan of Kansas. Welcome to committee.
Thank you, Madam Chair and Committee. We just wanted to take a second from United Healthcare to honor Corey Stoltz. So I know she's been a huge part of Johnson County Mental Health, and we had the great opportunity to work with her over the years. So we wanted to talk a little bit about what she's done as we have lost her this past December. So if we want to show the first slide and kind of talk about her program that she did with us. So we have the Corey Stoltz transportation program that was dedicated on October 28th of 2022. And Representative Landwehr, you were able to come and be a part of that. So we greatly appreciate that. And with Corey being part of the program, it involved Johnson County Mental Health and using those who were peers to help provide transportation for individuals to get to work, to get to appointments, and different things like that. So she had this brilliant idea of how can we use peers who've been through these programs to be able to help provide some of this transportation. And over her tenure there was over 400,000 trips that the program had provided. 300,000 of those trips were for those on our IDD waiver or for those with behavioral health needs. And then most of those were provided by the peers. And I think a really, really neat thing is right now there's on average 40 to 50 people that are providing transportation that are outside of transportation vendors that are able to help those on our waivers get to appointments, get to work, have full-time employment because of this program. And on average, there's about a 10% turnover for those involved in this program to work outside of the program that have full-time employment, that are working outside of Johnson County, that are able to kind of function and go about their work life on their own without having to be a part of the program. And a big nod to Corey is that in her time and with this program, over 1,000 people were able to gain gainful employment because of the peer program that she had created this idea for. So we just wanted to take a little bit of a moment and honor her life. And you can go to the next slide. And this is just a picture of her. And she passed away on December 22nd of 2023. But we just wanted to take this time just to think of her and just share all the great work that she did with this program. So I'm happy to stand for any questions.
Well, and committee members, it was a pleasure to have the opportunity to meet Corey. She was quite the firebrand. And she was very, very proud of, having put this together, but she was also a very, very humble individual, so it was sad that we lost her, but it was great to meet her, so. Representative Carpenter.
And thank you for that. One of the things that we've learned over the last few years is transportation is really so important, and there are so many different, around the state, there are very successful programs that provide transportation. I wish we could just kind of clone that around the state, and but anyway, thank you for that.
Yeah, you're very welcome. It would be wonderful.
Well, I think one of the things that makes this one here unique is the fact that it is peers, and so the clients feel, very comfortable being given a ride from someone that understands where they're coming from and what they're going through and stuff, so.
Absolutely.
Yeah, thank you very much.
Thank you.
Appreciate it. All right, next we have Casey Mullen, Senior Director of Clinical Quality, UHC. Welcome to committee.
Hi, thank you. Thank you so much for having us today. Thank you, Madam Chairman and committee. So today we wanted to present some quality outcomes that we've had at United Healthcare. Can you go to the next slide, please? Within our quality department, we do have a multifaceted approach to reaching out to members and providers and with our community engagement partners. With our members, we have value-added benefits, we have member outreach, and phone calls as well. As providers, we provide gap in care reports, education, and value-based contracts for our members to be able to receive services. And for community engagement, we support and participate in community events and promote wellness, and as well as education. So what we wanted to bring today to show you is we wanted to look at our physical health, our preventative health, our behavioral health, and then some of our other health outcomes that we have seen trending over the past 3 years. So for our preventative health, we wanted to look at annual dental visits, adult access to preventative care, and weight assessment and counseling for nutrition and physical activity in children and adolescents. We chose these 3 measures because it does incorporate a majority of our membership that we have at United Healthcare. You can see that over the past 3 years, we are trending in the right direction, which is a good thing, that more and more members are receiving services annually for their preventative services. All 3 of these measures range from adolescence all the way into adulthood, and then to our older members of our population. For our behavioral health, the measures that we chose to look at were diabetic monitoring for people with diabetes and schizophrenia, antidepressant medication management, and follow-up for hospitalization for mental health. With the AMM, the antidepressant medication management, and the diabetes monitoring for people with diabetes and schizophrenia, we also have performance improvement projects around those 2 measures that we've been working on as well. One thing I will note is you will see that the numbers are much lower, and the gradual increment increases year over year as well is not as much as the previous as preventive health. That's just because not as many members fall into those measures as they do just for the preventive health of the entire population. And then for other populations, we looked at testing and screening. We looked at chlamydia screening in women and lead screening in children as well. And over the past 2 years, again, we've maintained or increased our members who have received services and been able to be seen by their primary care providers. With continued increasing in our quality program. Also, we will continue to work with our community partners. We will continue to have member outreach, provider outreach, and as well as work with KDHE to try to increase those numbers and make sure as many members that need services, we're trying to reach out and get services rendered. Any questions?
Any questions, committee? Yes, Representative Reese.
Sorry, I have a lot of drinks over here. Not the kind I really want, but looking at your slide number 9, I believe, regarding behavioral health. And the one blue line that's at the bottom, the diabetes monitoring for people with diabetes and schizophrenia. Do you know what techniques maybe are trying to be used with persons living with schizophrenia and just trying to monitor diabetes and know that some of those medications are what's causing the diabetes?
Sure.
Do you know what's kind of trying to be tried with them, and whether that population will use the finger sticks to test for glucose, or are they eligible for the continuous glucose monitoring?
Sure. So with our members, we have whole person care, and we have care coordinators that reach out to them. That's part of our intervention with these members, as well as the PIP that we have, the Project Improvement Program. And then we also will send out information out to the providers as well, letting them know that these members are not compliant, or they need additional education, or tracking towards getting tested. So we will alert the providers, and then we let our care coordinators as well. They'll reach out, educate, and get them any services that they would need.
Okay, I would be interested in knowing more about that program and what kind of outreach is being done, because that's, it's a unique population of folks, and
It's a pretty small population too.
yes, it is, and if the symptoms aren't managed well right now, then it's going to be very difficult for them to look at, any kind of suggestions regarding medications, period, so. But I'd be interested in knowing more about that.
Okay.
Thank you.
Yeah, you're welcome.
Other questions, committee? I have a quick one regarding the CGMs, the continuous glucose monitors. Are those covered by, do you guys cover those? And if so, under what circumstance?
Yes, we do.
I see a head nod.
Yes.
In your phone a
I'm not
friend?
aware if we, yes, we do.
Yes, okay. And do you know if all of the MCOs cover those?
I would assume it's a
I'm
covered
also getting a
benefit
head
for
nod
all-
back in
yeah,
there.
for all
Okay.
3.
Thank you.
Yeah, thank you.
And I believe next we have Maria Weiler. Maria, are you in the room? Oh, we already had you. I apologize, Maria. I think we're ready for Melissa Lawson. I just didn't have the right people checked off my list. And you don't look like Melissa.
I'm not Melissa, actually. Good afternoon,
But you're
committee.
Chris, I'm assuming?
I am. I'm Chris Bierman, Director
Thank
of
you,
Community
Chris.
Development. Thank you. With that
Welcome.
and the Better Health of Kansas, and thank you all, committee, and thank you, Madam Chair, for the opportunity. We were actually going to work to show a video that we recorded this past summer about one of our member success stories about an individual named Daniel, who is on the BI waiver. Unfortunately, we just couldn't quite figure out how to make it work well so that everyone could hear in the room and everything like that. So we would very much encourage you all to go to our YouTube page to watch the video. I can provide that link to you directly. It's truly a compelling and heartwarming story about Daniel, who was on the BI waiver and everything that he went through and how our staff worked with him to be able to overcome the obstacles that he faced, not only on the BI waiver, but on substance use issues. He has been doing so great lately, and to me, I think probably one of the most encouraging things is it's a story of a member who appreciated our help, but really wanted to be on his own. And he's really close. And so that for us is probably one of the most exciting things. We like to obviously make sure that our members have the health care that they need to live their best life, but most importantly, fulfill their own goals in their life. And so it's an exciting story. So I would very much encourage you all to please check it out on YouTube when you get the chance. Now I'm going to pass over to Melissa, but I'll be back up in just a little bit.
We look forward to that, Chris. And welcome, Melissa.
Thank you. Good afternoon, committee. As the other MCOs have done, we wanted to present also some information about our clinical services, population health, and some outcomes that Aetna has experienced in the last few years. First off, a couple of our population health programs. The first one is ARC, Advancing Rural Communities. We have developed and are now executing this population health program to ensure and enhance services for our members in the most rural communities in Kansas. We utilize the community health workers in this program to connect these members to services such as telehealth, giving them better access to the providers that they need, to PICS Health, helping them with loneliness, depression, mental health issues, and then just overall bolster their mental health utilization for these members. And so we're really excited to continue to engage with members in the most rural parts of Kansas. Our second population health is Maternity Matters. We've shared information about this health program before, which is for our pregnant women and those who have recently delivered. But our most recent focus has been connecting with pregnant women as soon as possible in their pregnancy and then engaging them in care management, which we know provides the support and the resources they need, leading them to better outcomes. And we'll be, of course, continuing to work with our maternal members in this way. As far as behavioral health, we've continued to focus on providing robust support to members in need and the behavioral health support and services. We are ensuring that they are wrapped around in the various services that are going to assist, such as care management, outpatient services, mental health support platforms, again, such as PICS Health. And we're reviewing complex members in care rounds to ensure that there's appropriate and adequate services in place and consistent. And as a result, we've seen a decline in our behavioral health inpatient readmission rate, and you can see those numbers there. And then finally on this slide, emergency department utilization. The quality management department and the clinical service teams have collaborated, and we continue to collaborate to decrease the ED utilization of our members. We understand that some members use the emergency room for non-urgent care in place of seeing their primary care physician. And so we have been educating and executing various forms of education to provide information about what conditions are non-urgent, who the appropriate provider to see is, reminding them of our 24/7 nurse line for guidance, as well as encouraging care management engagement for members with complex conditions so that those conditions don't exacerbate to a point where they may need emergency department services. And you can see there that our utilization has declined as well. Next slide. So we've worked really hard the past 5 years to improve the health of our female members, understanding that the health of mothers, aunts, grandmothers, caregivers is critical in the overall health and stability of our families. We've executed multiple interventions to encourage screening and visits, expand care access, connect to care management, and provide education for better health literacy about the unique health needs of women. And while we've seen improvement in the measures shown on this slide, we know that we have further to go. And as today is is National Wear Red Day. I encourage everyone here to review the symptoms of heart attack and stroke, especially the women, and review your cardiovascular health with your doctor. And the next slide is just a summary of our current focused improvement projects and the various interventions for each. We continue to work through various barriers to improving these rates, and we'll bring rates and further results at a future date. Any questions about these before I turn it back over to Chris?
Before we go to questions, I'll just tell you that most of us in this room were wearing red yesterday because the committees were in session yesterday and the joint committees are today. So just wanted you to be aware that we support
Excellent.
that.
Thank you.
Any questions, committee? Yes, Senator Petty.
Yes, and the women in the Senate took a great picture, if you really actually.
I will go look for that. Thank you.
With all of our red on. So my question has to deal with the Maternity Matters program. And so do you have data about the number of clients that you have that have a pregnancy and how long you've been able to follow them, or that window of time?
There is, and we can pull that together in a detailed report for you and bring it back or send it to you.
Yeah, and I'd appreciate that. Because also including the percentage that have you increased the, I'm whatever that number is that you were actually having good contact with early on in the pregnancy,
right.
And how that's changed.
Yes, we know that for sure women who have engaged in our care management have better outcomes than women who don't, and we can certainly give you that information.
And just lastly about that, so when is there any then follow-up with Maternity Matters immediately after the delivery?
Absolutely, it continues. It's not just while they're pregnant, but after they have delivered, and until I think probably the next 18 months, or until the member decides to end care management engagement.
Thank you.
Mm-hmm.
Other questions, committee? And Madam Chair, we were ready for Chris to be back up to the microphone.
Thank you very much. I appreciate it. So the next slide that I'm going to be covering is actually the value-added benefits that we are offering to our members in 2024. And the three that I wanted to highlight are the three new value-added benefits that we're offering, which happen to be at the bottom of both columns. The first is the Healthy Food Gift Card Program, where we're going to be introducing a program specifically targeted at members with diabetes or congestive heart failure. We're hoping that these members will be interested in where we could provide them with $30 a month for at least 3 months to get a redeemable gift card that they can take into their grocery store and purchase healthy food items. It would be restricted to those healthy food items, and then we would also encourage our care managers to reach out to those folks and get them signed up for SNAP benefits if they're not already getting SNAP benefits. So that is one that we're excited about. The other two specifically deal with foster kiddos. The iFoster program, which we're incredibly excited about, and actually worked with both KDHE and KDADS before we have implemented this to ensure that this was something that both organizations were excited about. We will be providing a tablet to youth ages 13 to 17 or a notebook computer for those aged 18 to 24, along with digital literacy training through the program that's called iFoster. Therefore, they'll be able to have online resources to assist them, have something that can go with them so that their records are going along with them as they transition, but also to really help those foster kids get a good start on their movement into adulthood. And then finally, one of the things that we also are focused on, we call it our Foster Youth Transition Program. Last thing we want to see is these foster kiddos that are being transitioned into another home or someplace else. And so many times, unfortunately, they may have just a trash bag with their items thrown into it. And so what we're working on is we're going to be working with the foster care agencies as well as with others to provide them with a duffel bag that they can have. The duffel bag will not have a logo of ours on the outside of it because we don't want anything to say that this individual, you know, is on Medicaid or anything like that. But within that duffel bag will be some products that will help them in their transition. So we're very excited about those benefits starting up here in 2024. Next slide, please. It is also my incredible excitement to talk about our community investments that we made in 2023. Over $840,000 was provided by Aetna Better Health of Kansas to assist in the communities that we serve. Some of the highlights from this pie chart, we were able to provide lead testing machines for 2 providers, and we've reached out to other providers asking them if we could help them so that we could have more kiddos being tested for lead poisoning. And so we very much encourage providers that would like to do that to reach out to us for more opportunities. Maternal health, as we've talked about for a while the program that we've partnered with the University of Kansas on their Baby Talk program, that we are now with our dollars taken statewide to provide educational courses for mothers to ensure that their baby gets a healthy start on life. Through our IDD investments, we are very much supporting the Charting the Life course program. We've provided a $50,000 investment to Families Together so that they can implement Charting the Life course for their folks that they work with. 2 others I want to highlight. It was very exciting in December to be a part of a news conference to introduce the Kansas Behavioral Health Center for Excellence with Kyle Kessler and the folks from the Association of Community Mental Health Centers of Kansas. We provided them with some dollars to get that program up and running. And then finally, the work programs that we've been working on, we're going to be partnering with Wichita State University on their program to encourage more kids to go into healthcare, and especially those within the caregiver situation for folks with intellectual and developmental disabilities. And the last slide is just, we always put this in, some upcoming community events that we've got going on all around the state as we work to get out and do everything we can to educate members and community-based organizations on the benefits that are available to folks on KanCare. So that is my presentation, but I'd be happy to take any questions.
All right, thank you very much. Committee, are there questions for Chris? Senator Fagg.
Thank you, Madam Chairman. Thank you for your presentation. When you look at this 840,000 and you see like housing for 124.5, do people make application for that?
Actually,
what's the process to do that?
That's a great question. We actually work with community-based organizations such as the Kansas, I'm going to mess it up, the Kansas Association that works with 100 counties in the state, the Statewide Homeless Coalition just came into my mind, senior moment there, to help them to be able to work individually with the cases that they have. So we've also provided funds to the Manhattan Emergency Shelter, for example, so that they've got dollars to assist those members or those individuals that are needing housing assistance. So we truly focus the dollars on the community-based organizations that are working with those individuals to making sure that they're the ones that know their clientele and can serve them better. Hope that answered your question.
Madam Chairman, follow up. How do you know that you're getting a rural area? A lot of times you see the bigger towns know what to do and the little guys don't. So.
That's why we so appreciate the Kansas Statewide Homeless Coalition, because they're really focused on, they don't serve any of the areas that are actually served. For example, Wyandotte County, Shawnee County, Johnson County, they have their own organizations. So we truly did look for an organization that could go, all across the state to be able to provide these services. And so that's why we have actually worked with them on a couple of different investments to say, day, we want to make impacts out in the rural communities that don't normally get the assistance that they need. And so that was specifically why we worked with them.
Representative Reese. Last question.
Yeah, I've hit my quota already. She's given me one more grace period. On slide number maybe 6, I believe, one of the benefits is respite care.
Yes.
Which is fantastic. It's the next one. It's the respite care background checks that that Aetna will give one background check per year. Do you know how long it's taking you to do the background checks, or how long it's taking anybody to do a background check?
Unfortunately, we've not had anybody take advantage of that offer. What we were hoping to do, and thank you for the question because it's a great opportunity to talk about this. We'd love to see more folks take us up on this opportunity because the idea was because this respite care is only for those folks on the waiting list. The idea is if they've got a friend or family member that could provide the respite services, we'll pay for them to get a background check in order to provide that, and then also work with a provider that we have set up to get them paid for providing the respite services for the folks on the waiver waiting list. So far, we haven't had anybody take us up on that. We've offered it for a couple of years, and we don't want to remove it because we would want to make sure that folks that are on the waiver waiting list have the opportunity for respite services if they can't get them. Just because, they're on the waiver waiting list doesn't mean they shouldn't get the services they need.
That's good to know. Thank you.
You're welcome.
Committee, any further questions? All right, seeing none, thank you very much, Chris. Appreciate it.
Thank you.
Okay, committee, the really fun part of this committee is what we're going to start now, and that's our unresolved issues spreadsheet, which staff was kind enough to get it on big paper so we can see it. And I think, after enough years of working with this, I think we've gotten it to where we're a little bit more organized than what we've been, so we're not having to bounce back and forth. It's just a matter of trying to get things kind of consolidated as we've put things on, taken things off, et cetera. So we're going to start out first with Christine Osterlund, with Medical Director and Deputy Secretary for KDHE for the beginning of the list. So item 1.
Good afternoon, Madam Chair and members of the committee. So for the KDHE items, there are 7 of them. 2 of them relate to our public health division. So Madam Chair, if you don't mind, I'll cover the 5 that are related to Medicaid, and then we'll turn it over so we don't play musical chairs. All right. So item number 1 is related to inpatient and emergency room services for those waiting state hospital admission. I get to do the technical answer. You can see there's a reference to KDADS. They actually came up with a good idea and recommendation around how to explore this item, so I'll let them cover that since that was their idea, but I'll talk about it from a technical payment perspective. Obviously, this is going to be for Medicaid only. From a Medicaid perspective, there is not a distinguishing item or anything in our policy or payment around those waiting admission to a state hospital. So we're not going to know if they're, waiting admission to a state hospital or to be transferred to a nursing home. So our payment and policy is all just specific to medical necessity and other policies. So again, there's not specific provisions around this particular population, but like I said, KDADS will have a little bit more detail about a recommendation when they come up. Item number 2 is around CMHCs and CCBHCs providing some services to, again, folks in the inpatient hospital, jail, or other locations, again, while waiting admission to the state hospital. From an inpatient hospital perspective, Medicaid reimburses our hospitals what's called a DRG methodology, and basically what it is, we're paying a rate for all-inclusive care. And so services in this realm would be a part of that DRG rate. So if we were to try to pay them separately, CMS would consider that double billing because we're paying a DRG rate and then we'd be paying them. We do believe that hospitals could subcontract with them to be those service providers instead of using other psychologists or other entities. There also could be a possibility of carving out some of these services for our inpatient hospital population, so they could be submitted via professional claim, but that would be a lot broader than just those wanting to go to a state hospital. So again, some limitations there, but something that, we could continue to explore. I'm going to do an update on the part on the incarceration. There's been some late-breaking development. So traditionally, Medicaid does not cover services for folks that are incarcerated. We try to get them as they're coming out, except for some inpatient hospital-specific reimbursement. But CMS did just come out with guidance. We're going to get complete guidance in April where they're going to allow juveniles, and this would apply to juveniles only initially, but there would be some coverage available 30 days prior to release. And again, we aren't completely sure, is it going to be the full array of services? Is it going to be limited? Our understanding right now is it would be the full array of services, especially trying to get them aligned with providers and prescription medication so we have stabilization as they exit incarceration. So again, amending that one, I think there is going to be some opportunities in that realm where I think the CCBHCs and the CMHCs could play a critical role. That rule change will be implemented in early 2025. So we're a little bit less than about a year away from when it'd be implemented. So I think there's some really good opportunities there for coordination. The third one was on the CMS, what they call the core sets. You should have PDFs. We provided the PDFs of the 2024 adult core set, the 2024 child core set, and then HHS, because you can't have just one or two, you have to have three. They have some specific ones in their core set, so we provided that as well. So you should have a comprehensive list of what's covered in these core sets.
Committee members, this is what she's referring to.
All right, number four and number 5 are public health. So I will skip over those. I will go on to number 6, and this is around the presentation that you heard in a previous Bethell committee around the transmed audit. And the question was, what actions are KDHE taking as a result of that audit? So probably the single biggest item that relates to that audit is actually back in late 2019, KDHE had identified that the eligibility system was not picking up all of the transmed population to go into their renewal cycle, so their coverage could be ended. They actually prepared a system fix, was ready to implement it, and then the PHE happened, and we were told, obviously, we could not disenroll folks. So as soon as the unwinding ended, so in April of 2023, that system change went in. So that will allow us to more accurately capture these folks and put them up for renewal so we can end their coverage. But in addition to that, because obviously, you can't solely rely on a system, as a result of that audit, we've done a complete retraining of our staff. Some of that was necessary not only because of the audit, but just we haven't done renewals in a few years. But we did some specific focus on the transmed population, how to work those cases, what the policies were. We've also continued to improve some of our internal reporting and auditing where, we're doing sample looks at what our system is doing just to make sure, like for instance, if folks are on transmed, they're coming up at the end of their year, you're going to pull a report, make sure that the system and or the workers did what they were supposed to do, and we're going to be looking at sample sizes to ensure that both sides of the house are working as we expect them to. So we do expect to see improvement in that area. And then our last one for Medicaid is around the frail elder and the physical disability waiver. This is around case management and targeted case. Oh, sorry, number 7, sorry. Adding case management services to those 2 waivers and the cost to add it. Again, this is an overlap with a KDADS item. I know they're going to speak to this. I will speak generally that in the new RFP that is out, there was more detail and requirements around providing these services to the frail elder and the PD waiver population. What we did on the KDHE side is we have done our review to make sure that when that new contract goes into effect, is there anything from a CMS perspective or other regulatory perspective that we would have to have done and in place to allow that those services to be provided? And the answer to that is no. The only thing that will be required is that CMS will have to do their standard approval of the MCO contract as a whole. So we've just ensured we've cleared our path, and then, like I said, KDADS will talk about adding these services from the waiver perspective. And with that, those are the 5 Medicaid items, and I will stand for questions.
All right, committee, have you got questions for Christine? If not, I think what I'd like to do, committee, is to go, and I should have started this, Christine, when we were going through this, is we take each item, is to decide whether or not we keep it on our list or not. And committee, it's my opinion that number 1 can be removed. Number 2 removed. 3, I think would just give everybody the opportunity to look at the data and see if there's any further questions. Yes? Keep.
I think the question says provide a breakdown, and they did, but it's up to.
Right. And then you went to number 5 after that, didn't you?
6.
6.
Yeah, 4 and 5 are public health.
All right. And 6, I have, my note says, let's get an update at our next meeting. Agreed?
Agreed.
And then the final one, number 7. Huh? Okay, gone. All right, that's how we would like to roll that.
Thank you.
All right. Who do we have? No, scratch. We're getting rid of 7.
Yeah, we're keeping 6.
Yeah. Who do we have up next? Ashley.
Hello again, Committee. Ashley Goss, Deputy Secretary for Public Health, and I will address number 4, and then one of our staff is going to address number 5 for you. So researching number 4, this was to research testimony given by one of our home health agencies regarding the TB two-step skin test or two-step test for tuberculosis, as well as health assessments for those that work in home health agencies. Specific to that home health agency that mentioned that there were other issues involved, not just that. And so I just want you to know that information, and that's obviously information we can't share here. But regarding the 2-steps TB test, we have reviewed that. We did review it with our medical director at the time, and we are still in the process of promulgating our new regulations for home health agencies. There may be certain circumstances to where a provider could avoid that 2-step test, but it's going to be if they've had it in their past history, and then depending on their health assessment. So we're working through that with our medical director. But the point of having the 2-step is we have people going into other people's houses who may be compromised, and the last thing we want is for something to be shared with them because of an ill health worker. Do you have any questions on that one?
Committee? Are we done with it? All right, scratch.
All right, and I will call one of my coworkers up to answer number 5 for you. Good luck. Flip the pages.
Thank you, Madam Chair. Thank you, committee. I'm Derek Flerlock. I'm the Bureau Director for Family Health at KDHE. My dad is a cabinet maker, and so I'm very familiar with, like floor plans and things like that. So this is, I feel at home. Well, looks like I'm here to talk to you about childcare and facilities and general capacity across the state. This is number 5. So the first thing I do want to note, gave this update at special committee over the summer and then a couple of different times. The number of licensed childcare slots throughout the state, last time we pulled the data was actually at the highest point it has been since we had record of that data beginning in 2008. So that's very promising. I don't think it's quite yet where we need it to be. As far as facilities go, we've also seen an uptick in the number of licensed facilities we have across the state as well. I think what's interesting is we have seen a decline in the number of home providers, but an incline in the number, or an increase in the number of our centers. So when you look at trying to compare the number of licensed facilities versus licensed slots, what you'll notice is facilities really in the last 10 to 15 years, they did take a pretty significant dip, but with slots increasing because larger centers are opening and able to offer more care to children around the state. Some of the things we've done at KDHE to try to address this issue, of course, we've been working closely with other agency partners on this. DCF is the state lead on the early childhood plan, and then we come in and play the licensing role, the health and safety role in that. And some of the things we've done, we engaged in a Child Care Matters campaign, and this is really centered around professionalizing the career of being a child care provider. And I think too often what you'll hear, you drop your kid off and go to work, right? It's not as simple as that. Our child care providers are not babysitters. Your children go to a center, they go to an in-home provider, wherever it might be, and they're there to socialize with other children and develop as human beings. And that's really the point of childcare. There's a reason it's ECCE is the modern lingo, so early childhood care and education. We partnered with KDADS, and so that's been a good one to really promote the idea of intergenerational care, and that's this idea of doing child care in a long-term care facility. Now, there are two distinct operations, but there is the opportunity, and the onus is really on the long-term care operator and child care oversight to bring those two aspects together, but the facility matchup makes a lot of sense. And so we've presented on that a couple of times, Kansas Healthcare Association conference and flyers and promoting that interest as much as we can. And we've seen that idea really grow and take off. I know we have some other really amazing ideas going on in the early childhood space. There's work going on for a workforce registry at the moment, which is really exciting. And then I think from KDHE's perspective, we've just tried to make the licensing process in general more friendly, streamlining some of those operations, reducing the administrative burden, cutting the red tape, and increasing efficiencies where we can to get people licensed in a quicker and more efficient manner, and then improve our customer service as well. So those have been some of our biggest focuses. And if you guys have any specific questions, I'd be more than willing to attempt to answer them.
Committee comments? Representative Ballard, then Senator Petty.
Thank you for your presentation. I agree we are making progress, but at the same time, we are still very short on child care facilities. And you stated that part of it is private homes, and a lot of that has to do with the new licensing that's going on and the space required and the number you can have in your home, whether or not it becomes profitable to continue to do that or not. For that reason, I would say to the committee, we should keep this because it's still an ongoing process, and we need to continue to find ways to make it easier for the child care and at the same time have them be credentialed.
Absolutely. I would agree, Representative. Thank you for that. We have regulations that have been in place for many, many years, some more than others. I would be remiss to say that we have some current proposed regulations that are with the Attorney General's office that would do just that, give a little bit of flexibility in terms of our ratios that would allow more children in certain settings. We come up to federal standards as well. There's a whole list on those, but we've done a lot of work on the regulatory side to really listen to our providers, honestly, because we engaged with them, and a lot of what we've tried to do is do what we can to meet them in the middle sometimes, but just listen.
Senator Petty.
Thank you, Madam Chair. And Derek, thanks for that information. And could you just expand on that? Because those updated child care licensing regulations, where are they at? And how long have they been there? And where do they go next?
Yeah, they're currently with the Attorney General's office, so we're waiting final stamp from them, and as soon as we get those back, then we'll continue through the formal process, the Joint Committee on Administrative Rules and Regs hearings, and that sort of thing. So we've done a lot of the provider engagement, non-formal public comment ahead of this, but of course that'll come as well. So I mean, I think we feel like we've reached a good consensus. We also have a second packet, which is related to our school age and drop-in programs, and we were also waiting formal stamping from the Attorney General's office on that first packet to ensure streamlining language within the regulation for those out-of-school time programs, as we're calling them now. So, but that first packet is what we need to move. It's currently with the AG.
And it's been with the AG's office how long now?
We first dropped them off in October.
Okay. And so, so once it goes, finally does come from the Attorney General's office, and I'm just asking that because I think sometimes we've heard that the delay is with the department, but the department has promulgated those updates. They and gone through that process, moved them on through the process that's in place for that. And then, so once they come from the Attorney General's office, then it's not done yet.
It's not done. No, it has to go through. You've got your JCAR hearing, public comment, public hearing, all those sorts of things too. And we're actually currently working on an infographic of sorts to actually send out to the providers because, you know, we took a step back a couple weeks ago and said, you know, it's been a while since we've engaged with them directly on the regulatory side. Let's get something to them to say, hey, this is still moving forward, but this is the process, so they have a little bit better of an understanding, because it's confusing if you're not in it. So, and I do want to mention Senator Petty. We began the regulatory review in March and April, and we turned over those regulations finalized and stamped to the AG in October, and that's a very quick time, in my opinion, for an agency to turn over a regulatory review in the manner that we did. So I'm very proud of that and very proud of the team.
Right. I mean, it is extensive, the number of rules and regulations that are in place and that are important for the safety, health and safety of our children and the providers as well. Right. So I do appreciate that information. And I just wanted to give say I have seen some of those commercials, especially on the Topeka channel. And I always enjoy seeing them because I think they really do bring forward how important child care is and child care providers.
Committee, further questions? I would say that, staff, what I want to add to this is I want to know why it is that we're losing our home providers, because that's very concerning, I think, to me.
Can I expand on that?
Sure.
You know, one of the things the biggest thing I failed to mention is probably that lack of benefits for our providers. We hear about that quite a bit. We do an exit survey when facilities or providers exit the licensed space. On our end, we've just started that, so the data we have, you know, might not be reflective of too long, but it's modern. I think Child Care Aware as well has done an exit survey, and those are the things we hear about the most. They couldn't sustain operations, whether it was due to lack of benefits or they couldn't pay staff to keep things operating. And this is coming at a time now too where pandemic-related funds have transitioned away, and so sustainability funds gone.
How much staff do you think a home provider has that becomes a problem for them?
It depends. Typically 2. There's usually a licensed operator, and then it can depend. It depends on the home. Some have alternates that come in so that they can go to doctor's appointments, but the most don't. It's a very limited amount.
Right. Then we lost a lot of them when Lexi's Law went into place because we put a lot of regulations and stipulations on them. And for individuals that are complaining about how long this process is taking, we could have handled a lot of this had the governor not vetoed the legislation that would address this, and legislation moves a lot faster than what rules and regs does. So there's my commentary. So I want added on there is I want more detailed information as to why it is that we are losing the home providers. Committee, are there other questions, comments? Nope, I'm fine. All right, seeing none. Senator Petty, and I'm not going to go into arguments with you, Senator.
I thought I was having an opportunity to comment about childcare, but I'm not going to argue with you about anything.
Okay.
But I would say, if we're looking at keeping this on this list, that providing, because often it's, it does come up about our regulations in the past, it has. So providing information also, or asking the question about how many exceptions have been made to the rules to allow daycare providers to stay open or for centers to stay open. I think that's important to understand as well. Thanks.
Thank you.
Representative Ballard.
Thank you. You said you were going to add, so therefore we're keeping that so we can revisit this. Am I correct?
Yes, ma'am.
Okay, thank you.
Well, I know that was important to you as well to keep it, so I
Okay.
should have said that.
Thank you.
I think you just wanted to be able to point out that maybe I made a poo-paw.
I would have pointed that out. But I didn't. As long as we keep it.
You're always so bashful.
Thank you, Madam Chair.
Okay, you're welcome. All right, let's see, and so we've got Andy Brown, is that right? With KDADS. We haven't got to pick on you yet today. Let's go.
Thank you for your time. Happy to be here today, and we're going to report out on our outstanding issues items here. I do want to just preface by saying I'm not going to necessarily cover every word that's on this document, but for number one, for us, this is a carryover from 2023. And we're going to have ongoing updates about this. This is around the hospital down in the Wichita area. You heard a lot about that this morning, I think, from Scott, and got an opportunity to ask questions. So, but big headline there is just we have a site located.
Yep, and we're just going to keep that on there because it is an ongoing issue. So
Yep.
Thank you, Andy.
And then number two, this is also a carryover. This is from 2022. And this is around developing models for intensive community supports. KDADS Behavioral Health continues to work on distributing funds that we received last year through budget proviso, making sure that those are appropriated for fiscal year 24. So currently we've got 5 agreements that are getting ready to go out around that and begin services.
All right, committee, I believe you want to keep that, Representative Carpenter? Okay.
Number 3 is a combination carryover from 23 and 22. So on this one, we're looking at adopting language for assistive services that's similar to Technology First States. Our update on there is that we're still awaiting approval from CMS for the Smart Home Technology Project. We'll continue to provide updates on that.
All right, yeah, we'll just keep it for updates till we've got it resolved.
Number 4 is also a combined 22-23 issue. This one is around the Kansas Assessment Management Information System, or KAMIS. Right now, for the fiscal year 24 budget, we have $1 million in SGF to analyze the KAMIS system. We're working on posting an RFP to procure a third-party vendor to assist with that analysis, and that should be out on the street. So we're hopeful that we'll be able to identify a provider for that, and we'll continue to provide updates.
Andy, do you have an idea, and it's just been a while since I've worked with these budgets, isn't there's a federal match that comes in on this?
Yeah, the KAMIS
What's
system.
that percentage? Do you remember?
There may be another percentage. Okay, we think it might be admin, so it'd be 50-50.
Okay. All right, thank you.
So then, for item 5, this is a combined 22-23 issue. And on this one, right now, our staff is currently preparing policy for approval for the ABA therapy. So we'll continue to provide updates on that once those policies are finalized.
All right, we'll keep it. And committee, just because I say keep it, if you have a different, you're free to interject in it. I'm just zipping through it, so. Representative Carpenter.
Thank you, Madam Chair. So Andy, what is our hourly rate on that? I pulled those numbers from the ABA, and that's under KDHE though, isn't the state plan?
So I believe like the ABA therapy is part of the state plan. I'm not familiar with what the rates are off the top of my head. I'd have to look that up for you and report back.
Yeah, thank you for that. It's kind of confusing, but it's under the state plan. And I was looking for it and I was like, what, where is that? And it's in KDHE under the state plan.
Yeah. And there's billing that goes through the EPSDT program, which is for children. It's an early early periodic screening, diagnostic treatment. There we go. Yeah. So it's under that set of benefits, and we would have to. I'll look up and see what we can do about getting you rate information. Yep. So then for number 6, this is
How long does this take? This has been on here since 2022.
Well, we need a staff member, so we're working on trying to hire a staff member. I hope that we'll be able to do that soon. And we'll look and see if there's anything we can do about working on it in the meantime. But currently, like, we have a vacant position that's responsible for that waiver.
Yeah, on number 6. On number 6.
No, I'm serious. It's taken a long time to get.
Yeah, tell him.
Oh.
You can talk to Andy. He doesn't bite.
Oh.
If he does, you just poke him back.
Oh, well, Andy and I know how to have mutual respect for each other, right?
Yes.
There we go. No, the only thing I was looking at, when they pointed out it was 2022, but that's still like at the most a year and a half. And it seems like a lot of our positions are taking longer because of the specific needs that we have as well as the workforce shortage. Am I correct?
Yeah, I believe those are all related issues.
See, we agree.
She's just being nicer than I am because she likes to do that, Andy.
Yeah.
Thank you.
Okay, we're going to keep it.
All right. So then moving on to number 7, I was originally, Christine asked me to speak to this. We came up with the idea of having a convening with KHA to talk about this particular issue and see if we can dive into some more details to help answer questions around this. There is overall just a current payment mechanism that Medicaid uses to reimburse hospitals while patients are in the emergency department. But we felt like there might be some ways we could work with KHA to come up with maybe some other solutions as well.
All right, we'll keep it.
I think you might have scratched it on the KDHE side, so double check.
Okay.
Trying to get it off of my list.
Maybe it was worded different, and we didn't quite understand that.
Yeah, but I do think we've got a good plan for moving forward on it.
Okay. Well, how about if we do this? We just keep it on the KDADS side, but we know that KDHE is involved. So if staff can just monitor that, then we don't have it in 2 places. Is that good?
We just stay out of that fray.
All right.
Well, yeah.
Yeah.
Okay. All right, let's go to number 8.
Okay, so again, number 8, KDHE already responded to this one as number 2 on their list, but we support their position on it. And we also, I think, want to point out that like a lot of that requires partnerships at the local level between the hospital and the CCPHCs.
So there's not really a whole lot we can do on that.
Not much.
So we'll remove it. Yeah, but now we got to find one for KDHE to be added back, so.
You don't have to balance the scales. You're fine. For number 9, This is around what policy changes would be needed to reduce wait times for competency evaluations and treatment. Right now, I don't think we've been able to identify any statutory changes that we want to pursue in this session. But the Governor's Advisory Council, or excuse me, panel for the South Central Region Psychiatric Hospital, i.e. the Witchita Hospital, is planning to study competency statutes and processes as part of their program design for the new hospital. And that may lead to some things that we might bring back next session.
All right, we'll go ahead and keep that. Number 10.
Okay. And then for number 10, this is around determining the root cause of antipsychotic drug use trends and looking at having us measure compared to other states and look at the state ranking. So we've provided some of that in the testimony around survey and certification, and I think that was included in the packet.
What are you going to do?
I would keep it.
All right, we'll keep it. Number 11.
Okay, so number 11, this is around what point do the individuals go off the brain injury waiver due to no additional improvement? KDADS reviews, those are held every 6 months and more often as needed. So if during one of those reviews it's determined that it's appropriate for somebody to come off the waiver, that would be the frequency at which that decision might be evaluated and made.
Okay, Andy, as I look at this here, and there's a comment, we have some individuals who don't make progress with one provider but change and the next provider has more success. Does that mean it's a different type of provider?
Well, it might be a difference in approach that the providers have, possibly, or a different model that they're using, but I think it's a reference to moving from like one cognitive therapy provider to another cognitive therapy provider, for example.
I don't know, I'm in between on this one. May I ask a question?
Yes, Representative Ballard.
Do we have a waiting list?
I believe there is a waiting list for the BI waiver. No.
No, there had best,
No.
there had best not be.
Okay.
Well, the reason I was asking that because
We was ready to take you down, Andy.
Yeah.
Right, well, we went into both. Yeah, all of a sudden it dawned on me because, when we did the acquired versus, the other one, it seemed like we had a rise. And we were afraid at one point, did we have enough money to cover the number? But we were able to fund it, so that's what makes me wonder. I don't know, I guess my gut level feeling is that there's always something around brain injury, but I don't know if keeping this on is absolutely necessary at this time unless we have some reason to say there's a specific area to look at.
I would agree with that as well. And Senator Petty did.
Oh. Oh, my goodness, let me put that down. Okay,
She agreed with both of us.
all right, there you go.
Oh, wait a minute. Really, Representative Reese?
Susan has it.
Go ahead, Representative Reese.
Andy, could some of the reason be because the person with the brain injury also has other diagnosis? They may be dually diagnosed.
I don't think
substance use involved.
So Michelle's nodding. So I don't know what all the factors are. I'll let Michelle come up and answer that question.
Would you like to do that for us, please, Michelle?
More complicated.
So as far as people moving on and off the brain injury waiver, often people have more than one diagnosis with the brain injury waiver. A lot of people
Depending
who
upon
have
the type of brain injury waiver.
It depends on it. Like for the traumatic brain injuries, a lot of those come from terrible car accidents or motorcycle accidents or fights, whatever, falls. And then for the acquired brain injury, those generally are people right now, 40s, 50s, 60s, who are getting the stroke-induced brain injuries.
Does that help? Okay. All right, so we're going to remove that one. Because it can always be brought up if there's questions that arise over the time, but I don't think we need to leave it on the list. Number 12.
Okay. So number 12 is related to what's KDADS doing to lower the number of Kansans on the BI waiver that do not receive therapy for services to under 100. So for those individuals that are not closed before Appendix K closure in November of 23, the MCOs are now completing reviews with the participants and submitting closures or transition requests for the long-term HCBS waivers. So the individuals that meet those eligibility requirements are being reviewed. We also have some individuals that are waiting for a therapist to become available who will not be closed. And we're experiencing network adequacy issues, which were referenced earlier by Barbara Ballard, that the MCOs are also working to resolve.
All right, we'll keep it.
All right, so number 13.
You had your last question earlier, Representative Reese, but go ahead.
Thank you, Madam Chair. Andy, on this one too, I know some of them are waiting for a therapist. And the MCOs can, they're supposed to ensure individuals who are not in compliance with the program guidelines are closed out timely. Do you know, I don't like the word compliance, but do you know what criteria they're using in order to close somebody and not around compliance?
Yeah, I don't have that information in my head, but I will check and see if Michelle does. Yep, okay.
I don't know all the reasons, but sometimes people fail to participate in the service planning or fail to participate in the therapies. There's a number of services on the waiver, but one of the criteria for this waiver is that you absolutely have to participate in at least one of the therapies. And some people do not do that, and we eventually, they have to close them then.
Is it like one therapy within 30 days or something like that?
Within 30 days, in a 30-day period, they need to be participating in that.
And I would hope that the MCOs would be doing a lot of outreach to try to get the person engaged.
Yes, and they know that this is a challenging population to work with, and they do make a lot of effort to reach out to these people and make sure that they have an opportunity to participate in the therapies.
Great, thank you.
Mm-hmm.
All right. Number 13.
So for number 13, this is about the waiting list for the PD waiver. Right now, KDADS sees increases as part of the impact for the increase of the protected income level, which has gone up twice in the past few years, which is making more people eligible for the waiver with an increase to the 300% of FPL.
All right, I think we're going to keep it at this time just to monitor as we watch it.
Yep. So for number 14, right now there are 5,096 people on the ID waiting list. And this is a question about, are there ways to expedite the community support waiver? We've already talked about that a little bit today. But we are working to expedite that as quickly as we can. We currently have the task order out that we're working on securing somebody to assist us with the writing and application of that waiver to CMS.
Senator Gossage.
Regarding the waiver, we have a gentleman who was here with us this morning. He had to go back to work. He had written testimony, been in touch with him as a constituent now for months. His daughter has been on the waiting list for now since 2013. He did go to KU in Lawrence to help out to try to further things along by taking that survey. Was there on November the 2nd. Here's his response. So my family went to KU in Lawrence to help them by going through their survey before it was sent out. To be honest, it was the most unorganized survey with several redundant questions, very confusing. I would guess if it was sent out in any form that we would see people are going to think it's too difficult, not to the point, and they won't complete it. I hope I'm wrong, but it looked like a train wreck. So I'm glad to hear, and I'm not blaming the gentleman sitting back there who was speaking from KU. He said he just started with them. So I'm hoping that we will also, as part of the IDD waiver, wanting to get this community support waiver going as quickly as possible, that we would urge them to have a survey that is something that people actually will fill out and get right to the point of what we need. Thank you.
We'll keep number 15.
All right, so for number 15, this is the question about how workforce impacts the wait list, and asks about a career path to retain and increase direct service providers. So right now, KDADS is working with KU on a direct support worker study to assist determining the best methods for retaining direct service workers. One of the things that we're looking at specifically has been the impact that assistive technology may have on expanding that to allow for people to live more independently and reduce the overall need for the workforce to some degree. We're also looking at paid family caregiving to make sure that that's retained during the unwinding from Medicaid.
Number 16.
All right, so number 16 is about what's the benefit to the individual to have case management services on the frail and elderly and the PD waiver and the cost to add it. So these are highly vulnerable people who often require assistance in many areas of their lives and remain in the community. And that's why in our current RFP for the MCOs, we've worked with KDHE to develop community care coordination plans. So we're looking right now through that RFP process to help evaluate the MCO applicants on what their care coordination proposed structure looks like.
We're going to keep it at this time. Number 17.
So for number 17, this is also number 2 on the DCF list. This is around investing in foster home recruitment. So DCF has been working with us and on the recruitment for new foster homes and to develop additional therapeutic foster home placements. KDADS specifically with the BHS has executed contracts for the development of 2 new children's crisis centers. We are currently working to expand that through additional grants and funding mechanisms. We're currently reviewing what else we can do to expand that. We have several groups that are interested in adding those types of services to their community. Additional funding for those children's crisis services would allow for greater development of those crisis respite beds that would help alleviate stress that results in disrupted placements. So we're hoping that those can be sort of a KDADS behavioral health component while DCF is working on developing their therapeutic care homes.
Representative Carpenter.
So Andy, I saw our wait list is up to like 156 now. These beds here, do we still have, I mean, I know last year we had 108 beds scattered around. Do we still have those beds that we just can't staff?
Yeah, there remains to be a staffing issue within the PRTFs around being able to meet having their census numbers equal their license numbers.
Yeah, that's just been an ongoing thing since COVID, and we could eliminate the wait list or come pretty close to it if we just had the staff.
Yeah.
So do you want to keep this item, or?
Yeah.
I'm just wondering if we don't want to add, because what I don't see in here is unless I'm just, because I'm trying to scan this as I'm looking at, is what Representative Carpenter brought up with the staffing issue.
Right.
And the beds. So I think staff, that needs to be a comment added that is one of the problems that we're facing. So as we go forward, we keep that in mind. It's not just a handful of people. Representative Concanon.
Thank you, Madam Chair. Andy, what's the timeline on the training for the therapeutic foster homes?
I will defer that question to DCF, I think.
Okay, I'll wait, catch them. Thank you.
Just a moment here, I'm making notes. All right. Is that it?
I think that's it.
We're done? Well, I don't know. I haven't gotten to pick on the secretary either today, so. We'll work on it. Something's coming up, I can tell. Thank you very much, Andy.
Yeah, thank you.
All right, judicial branch. There she is. I couldn't see you back there. Welcome, Marissa.
Thank you, Madam Chair. Marisa Bayless, Special Counsel to Chief Justice Lukert. I believe our only item is on page 10 of the spreadsheet. The issue concern was what specialty courts are available and being used for family treatment. So last year, in partnership with Senator Baumgardner and Justice Stanridge, Chief Justice Lukert, we had talked about the idea of a child welfare summit. We are having that child welfare summit in April of this year here in Topeka. Along with that conversation is what can the judicial branch do differently, or what can we do and work collaboratively with DCF and KDADS on a different option in the child welfare system that may be good for some participants. One thing we talked about is family treatment court. The family treatment court model is a specialty court model. It will be new to Kansas, but it is operational in other states. This steering committee that we have formed with DCF and KDADS, some of those members were able to travel to Iowa to watch that state perform their family treatment court. Some were also able to go to Oklahoma, who also has family treatment courts. So family treatment court really combines the model that we know works, which is adult drug court, and taking that with child welfare. So to be eligible for a family treatment court, the family has to be involved with the child welfare system, but one of the parents must be diagnosed with a substance use disorder, either in a moderate to severe area, and that's really the primary reason why they are not able to have a unified family member, and the reason that they are in the child welfare system. And so that steering committee has done a lot of work. Right now, I know they are in the process of finalizing some interagency MOUs. They're also developing a policy and procedure manual based on the national family treatment court standards. So when our 3 pilot programs, which are going to be in Cali, Lyon, and Miami counties, they are slated to start in September of this year. They all will be operating from the same standards. We'll be able to assess them the same way, use the same metrics for success. The idea for this pilot program is to run roughly around 18 months and to see where we are after that, what needs to be developed more, what problems are we seeing, anything that needs to be changed within those areas. So we're very excited about this possibility, this new thing we're trying. And really just great partnership between KDADS and DCF and the judicial branch to get this going and see if we can try something different.
I'd say committee that we keep it just so that we can see progress. Representative Carpenter.
Thank you for being here.
Yeah.
So is the money still in the governor's budget to fund this?
So that was in KDAD's budget, and I would defer that question to KDAD's.
Can someone from KDADS answer that for Representative Carpenter, please?
Yeah, we're currently in the governor's budget recommendations for 1.5 million.
Very good. Thank you.
Thank you. Committee, further questions? All right, seeing none, we're just going to keep it on just so we monitor the progress. Thank you very much. All right, DCF. Welcome, committee, Tanya.
Thank you. It's good to be here today. We just have one item. I understand it's number 2. And as you know, it was number 17 for KDADS. So you heard a little bit of the answer already from KDADS. So this is about investing in foster home recruitment and retention by increasing funding for supplemental training to support youth who might have serious emotional disturbance. So very quickly, in state fiscal year 23, DCF added funds for each child placing agency if they wished to have an additional recruiter position to help them recruit family foster homes. They could opt out if they wished, but we just increased their funding by 1 additional position. That occurred in state fiscal year 23. We already had flexible rates based on the needs of a child, and we also have a separate daily rate reimbursement structure for family foster homes for children who might be living with an intellectual or developmental disability. So that's in place to support retention and recruitment. We also, last year, the budget included an additional $5.1 million so that we could increase the daily rate of relative providers to 70% of the licensed family foster home rate. Statewide, about 47% of children, they're living with a relative or kin. And in the Kansas City area and southeast regions of the state, over half of children who are in the custody of the secretary are living with a relative. So we wanted to make sure we increase those supports too. In terms of training, DCF awarded a grant to the Kansas Center for Autism Research and Training. They were interested in being able to develop and deliver training supports and resources to foster parents and caregivers. So we're excited about that new partnership, and we got that grant done last year, or state fiscal year 23. The Children's Alliance does training for us, and they have ongoing training. They're also very innovative and want the best in terms of newer resources. So they do always have topics on adverse childhood experiences, the trauma-informed relational interventions. They have a core for those who are caregivers for teens. So they have a lot of resources, and we really appreciate them and their training and being on the leading edge of that. And it's been mentioned today that DCF created a therapeutic family foster home level of care for youth. We created that, and we were fortunate last year in our budget to get a legislative enhancement of $6 million to build capacity for therapeutic family foster homes. About $3 million of that we set aside so that we could do capacity building grants. We're in the process of reviewing an RFP and preparing awards. So we had folks who are interested in being part of that to build that capacity, to send in proposals and tell us what they'd like to do to build the capacity of therapeutic family foster homes in their community. And so we hope to be able to share information on those awards soon. And those are my updates. And we just had one item, and that's what we've been doing, investing in family foster home recruitment.
All right, and I think at this point, we're just going to keep it there just to kind of keep an eye on it and monitor it. So I appreciate that a lot.
Okay.
All right, committee, that is our spreadsheet for today. Representative Carpenter.
Elizabeth, I want to thank you for this spreadsheet.
Oh, take my thunder, will you? Go ahead, Representative.
Sorry about that.
No, you're not.
I probably needed a little bit more than Landwehr did,
No.
so that is very nice to have it full-size like that. So I apologize if I did take your thunder.
No, that's fine. I was going to say it was so much nicer to work with. My eyes aren't stressed. And I think also getting it narrowed down so that, and keep in mind, we don't lose data that was there before. It can always be gotten. But this just keeps us on target. It's kind of like having a checklist at each one of our meetings so we don't forget things to re-talk about. So I want to thank staff for that because it's not easy. And also thank staff for all their work of putting this committee together, because especially during the legislative session, they've got a lot of duties. This is not an easy committee to put together. especially trying to chase me around and find me and nail me down to ask questions and get answers from. Committee, our next meeting right now is scheduled for April 24th. Just kind of a heads up, that may or may not change, but that's where we're at right now. And so till further notice, we are, what? Oh, the KU survey, by the way, staff has received it. That came out, has been sent to you. So that's my last announcement. Representing KanCare.
The survey they talked about, the survey that KU was doing, they've received a copy of it.
It's the
so we'll
Wednesday
get it.
before. Yeah, but that's what, right now it's just kind of tentative because of some other things in the works. All right, we are adjourned till further notice.